Hello. Hello. Good morning. Good morning. Good morning. We don't sound like it's a good morning. Good morning. All right. Good morning, everyone. It's the day 2 of the Digital and Data Use Forum 2024. Okay. So before we start the day, could we all stand up, please, and just stand up for the national anthem to open the day, and then we get on with the day. So can we please be on our feet? Thank you very much, the media team, and thank you to all you patriotic citizens. So moving on, yesterday we did say that there were a lot of things to expect today, a lot of interesting topics, and a lot of big wigs to meet here to say that we already have some big shots in the room, and it is my pleasure to just recognize a few of them while we wait for the rest to join us. So please put your hands together, and I want it to be as enthusiastic as possible. We did not have this particular person in the room yesterday, but we are very, very honored to have him in the room. He's the country director of DataFi Nigeria, and his name is Ose Ogori. Please put your hands together for him as we recognize him. We also have in our midst another big shot from the Federal Ministry of Health in the person of Dr. Leke Ojewale. Please put your hands together for him as well. And the farther it goes, the bigger the shots get. So it is a pleasure and an honor to also recognize Dr. Olumide Okunola from the World Bank. Please put your hands together for him. And then we have another person joining us from the World Bank. She's joining us virtually. I don't know if she's online right now, but it's also is waving at us. So please put your hands together for Marilise Gorgeons, please. All right. So I'll be co-hosting today alongside, again, my wonderful co-host by the name of?
Abba, for short.
Thank you. So Alba and I will be co-hosting today, and to kick the enthusiastically. Keep clapping, keep clapping. Thank you so much.
Thank you. Good morning, everyone. It's a pleasure to be here to, I don't know if it's to welcome you on the second day. I was at Edo State to commission the Integrated Public Health Emergency Operations Center for the state. I think it's the first integrated emergency operations center for Nigeria. The governor was there, and also the consular general from the U.S. Embassy in Lagos, or U.S. Consulate in Lagos, he was also there. That's why I was not available yesterday. However, getting to the airport, we know what happens when you get to the airport. The flight got shifted until I boarded when the last session was almost ending. But I'm grateful that I'm here today. and I want to apologize for missing yesterday's session. But that said, I want to say thank you to everyone for coming in here and for being part of this session. The Digital and Data Use Forum is not only a learning platform for us, but also a platform for us to collaborate, a platform that will open partnerships, a platform that will also showcase what we have done in the health space in Nigeria. And like was presented yesterday in one of the sessions, we talked about one of the solutions or the products that we support as DataFi. It's a homegrown system developed by Nigerians for Nigeria to meet our peculiar health needs. And it's one of the things that we need to celebrate as Nigerians. And this platform offers us the opportunity to be able to celebrate that. I want to say thank you to the Ministry of Health, from colleagues from Ministry of Health, from colleagues from the World Bank, and also from the various states that we support. Please, can we just give a round of applause to the states that we support? We have the DG TACA here in the room. We have the DPH from Edo State. DG TACA means the Taraba State AIDS Control Agency. The DG is here with us. We also have various people, directors, officials from Akwa Ibom, from Bauchi State, from Edo State, from Cross River State, Adamawa, Oyo. Which one am I missing now? Kano State. Yeah, I think there's one more. There are 8. Niger State, yes, Niger State. So I want to say thank you very much for coming. And from the discussions I've had this morning, it's been a very fruitful deliberation. It will continue today, and I want to say thank you for joining us. Also, thank you to USAID for funding this event. USAID has been a worthy and a very consistent partner. I want to say thank you to USAID and the government of Nigeria. I've mentioned them earlier. And finally, to the DataFi team who has put this together. It's really great. And please give yourself a round of applause. Thank you very much for this. I don't know if it's a vote of thanks I'm doing or a welcome remark, but I think it's better I do it now than I forget later. So thank you very much, everyone, and look forward to a fruitful deliberations today. Thank you.
Please, may we put our hands together for Ose Ogori. He's a remarkable, able, and reliable leader. And when you think of DataFi Nigeria, he's the first person that comes to mind. He's the 001 of DataFi Nigeria. Thank you so much, Ose, for that warm opening remarks. To not waste our time further, the first session we have today is a talk on digital in-health strategy and the role of partners in Nigeria. And to take that session, it's an honor to invite to the stage the program lead for the Nigeria program of the Health in Africa Initiative and a senior health specialist at the International Finance Corporation of the World Bank Group. He leads the work on private sector participation in health systems and has been involved in the conceptualization, design, and implementation of several pro-poor risk pooling schemes in Nigeria, including the Catastrophic Health Fund. He also undertook some graduate studies at the London School of Economics and the University of Oxford Said Business School, where he earned master's degrees in health policy, planning, and financing, and major program management, respectively. He also graduated with an MBA from the Said Business School at the University of Oxford. Like I said, there are big wigs in this room. So please put your hands together for Dr. Olumide Okunola as he makes his way to the stage. Please clap for him. Thank you so much.
Thank you. That's probably my bio from a few years ago. So good morning, everyone. It's a pleasure to be here. And what an opportune time to be at this event. When we got the invite from DataFi, we felt it was something we needed to partner with the team. But this occasion won't be the end of it. We hope to work very closely with the DataFi team and, in fact, with all of you. As you will hear in the presentation that myself and my colleague, Mary-Lise, please if you can show Mary-Lise. Mary-Lise is our lead on digital in health at the World Bank globally. And as you will hear from what Mary-Lise will be talking about, she's worked, in fact, Mary-Lise currently is in Indonesia. So she's worked with both the Indonesian and the Indian teams to scale up digital in health. Two countries, very large countries, federations like Nigeria, complex as you can have it, different paths, and she will share a bit of all of those. And then the choice will be for you to see which way Nigeria. Though I must say that the story of Indonesia in particular resonates with me, because whatever it is that Indonesia has achieved actually happened in the last 4 to 5 years simply because of COVID. So let's take a step back before our presentation. In fact, when Otse was giving his welcome remarks, that began to show one of the challenges we have in digital in health. So, USAID, great job, great resources, said, look, I have 5, 6 states, Yobe, Taraba, and supports initiatives there. FCDO, pick another 6 states, support initiatives. World Bank, everybody does different things, but they don't speak to each other. This is not just in digital in health, but across the health system. And that's why we have not been able to make the kind of rapid changes that we require, either in digital in health or in fact across other parts of the system. And I do hope that perhaps one of the things that Dr. Chris Esopong, Director HPRS at the Federal Ministry of Health, shared with you is the ongoing transformational health sector reform. We're excited about that reform, and I will spend some time to bring you up to speed to complement what Dr. Chris had spoken about in terms of the health sector reforms and why we need to go down that route, but in particular, emphasizing the role of digital in health and what you should expect and why we need your insights. So without much ado, I'll yield the floor to Mary-Lise to give us a global perspective, what will be relevant to us, so that as we then go into a Nigeria-focused discussion, I will share with you after her talk how the request the Ministry of Health has made to us as the World Bank and what we're doing with other partners in the next few weeks. So it might be very important to do a couple of things. One, make sure that you take Benga Jaudola's phone number, Leke Ojewale, and there's a guy called Mutaka. Very important people because they will be leading this charge. Very, very important. Two, get a copy of the Digital in Health book, which is being circulated. Third, listen to what Mary-Lise has to say, and I will close it out with a few things I think might interest you. So Mary-Lise, I think the floor is up. Take it away from there, Mary-Lise.
Can someone just confirm that you can hear me?
We can hear you online, Mary-Lise.
Okay,
Thanks.
excellent. I hope participants in the room can hear me as well. It would be great if somebody just confirms. So I'd speak into a void.
Yeah, Mary-Lise, we can hear you. Just confirming in the room.
Excellent. Thank you very much. Thank you very much. So it's my pleasure to share with you today some thoughts around what it is that we can do to improve the way that digital and data technology can transform healthcare. The first thing I think we need to do when we talk about digital and data technology is to first recognize the immense value that digital brings. Those of you who chose to spend your time yesterday, we try and think about the different ways in which a digital ecosystem can add value. First, it will add value for patients by helping to make health personal and reduce health differences. We know, for example, that patients who have access to their own health data have higher satisfaction levels, have more trust in the doctors they visit, are more likely to follow up and adhere to their medication, and even have better blood pressure and glucose control. We've seen in some studies up to a 25% improvement. The stakeholders we tend to not always put first when we think about how digital can add value are healthcare providers, but we know that digital can add immense value for healthcare providers. We know that they're more likely to be satisfied in their jobs, more likely to have good work-life balance, and we've even seen that countries that have adopted digital payments for community health workers have seen higher retention rates and even more volunteers available to do the work. It can also help to improve health financing. In fact, there's one study that suggests that in the 3 large economies in Africa, Nigeria included, the country can save up to 15% of its total annual health system costs by focusing on telemedicine and electronic health records. In India, we've seen the benefit that telemedicine has had in decreasing costs per patient per year. We also know that countries that have had better levels of digital adoption prior to COVID had better and earlier responses to COVID. We know that it can add convenience and better outcomes for patients, as the Nairobi illustrates. We know it can add value for patients, as on the right-hand side, the examples from Indonesia shows where their digital health system has already added significant value through the examples that are listed here. And this is, again, from a client in Indonesia that spoke about the value of the WhatsApp notification that she received regarding immunization. It will help make staff at lower levels, community health workers, be able to connect more immediately and instantly, and so provide better and higher level care to all patients who need health services. You can see here that there was the higher the level of the digital adoption on the horizontal axis was associated with fewer new cases of COVID after the initial peak. So being ready and being resilient means also being digitally ready. This also shows you that in most cases, it was digital infrastructure in 24 out of the 70 cases assessed here, where digital infrastructure was the main thing that resulted in countries being able to better respond to COVID. What is the state of digital health maturity around the world? This data from the Global Digital Health Monitor can show you the state of digital health maturity around, in countries of different income levels across the 7 dimensions of digital health maturity. Not a surprise that countries in high-income countries have higher levels of maturity. If we look at West and Central Africa, you could see that West and Central Africa's digital maturity is lower than the rest of the world. We know that there are significant challenges, and those of us in the room today working in data and digital are aware of the challenges of inefficiency, the lack of standardization, duplicate data collection, concerns about privacy, significant concerns about hyperfragmentation and the lack of interoperability, concerns about endless pilots and no scalability, as well as concern about patchy adoption of digital tools. So in looking at these challenges and recognizing the progress and the value that can be unlocked with digital and data, the World Bank produced a report last year and would suggest that the focus needs to shift to address these challenges. The focus needs to shift from digitalization to digital in health through a national health tech ecosystem. That means we need to think digital in all aspects of health systems and all aspects of health service delivery, whether that's health financing, health workforce management, pandemic preparedness, supply chain, pharmaceuticals and nutraceuticals, climate change in health, nutrition. All of these areas will have digital components to them. Just as when we do banking these days, there's a digital component to all financial services that we access, whether it is looking for balances online or transferring funds. Digital is in financial services. In the same way, digital will become an embedded part in every aspect of healthcare delivery and health system management. What is it that will be necessary, and what have we seen looking at examples like India and Indonesia? What does successful digital in health systems have in common? First is that they're distributed, recognizing that healthcare doesn't just get delivered in fixed health facilities. Second, that they are connected without sharing data across boundaries, be that the boundaries of a facility, the boundary of a state, the boundary of a different individual program, whether a TB or a malaria program. Unless data are shared, we will never unlock the full value of the data in that system for the patient and for the system. It is also continuous, because we know that working to improve health is a continuous process. It is human-centered, decentralized, collaborative, and responsive. What does that mean practically when we talk about a digital health tech ecosystem to support the wider health transformation goals of countries such as Nigeria? First, we have to think about creating one health data space, the red circle in the middle. Second, we know that there are and will always be several information systems. Here in Indonesia, where I am at the moment, there are 400 different EMRs that were connected into one distributed network in order for the country to create one complete health record per patient. And then we know that there are several technologies, some used in the home, some used at facilities, digital health interventions that keep generating new and use existing health data, and they feed into the information systems, which then create this one health data space. So the question is, how can we move to create this ecosystem in an integrated way? One of the steps to India's success has been the notion of federated architecture, where all the data is not necessarily sitting in one place, but there is a federated way in which distributed systems capture data in semantically consistent ways and exchange that data in a secure way, whilst every individual information system retains the ownership and the protection of that data. In order for countries to move from where they are to this notion of one integrated but distributed health tech ecosystem where both public and private sector players can play, there are three essential areas that countries need to focus on. Prioritize, because we cannot invest in all digital technology at the same time. And particularly with the current arms race that there is for AI in health, I think this is an area we need to be particularly mindful of. Second, connect all the hyper-fragmented disparate dots. Third, scale, figure out which interventions work, scale them, and not have endless pilots, together with the governance that's needed to make that work. In fact, for each of these priority areas, if you read the Digital and Health Flagship Report, you will see that there are 10 recommendations for action. I know we have circulated copies of the report. In this QR code, you can also download the report, the summary, as well as implementation briefs about how to make this a reality in countries that is available online. So let's move from the global and the regional to Nigeria. Where is Nigeria? If we look at the Global Digital Health Monitor data on the horizontal axis, and we look at the maturity of digital transformation across all of across all countries on the vertical axis, you will see that Nigeria's digital health maturity and digital government-wide, society-wide maturity is still quite low. So clearly there's significant work that needs to be done. In fact, if we compare two countries that are very similar in many ways, federated systems, Indonesia is immensely geographically fragmented, 17,000 different islands, 60,000 health facilities. If we compare, the gray that you can see is the global average for each of the digital health maturity dimensions, and the blue is the specific country value. So you could see Nigeria, not quite where the global average is, and you can see Indonesia that is exceeded in many dimensions the global average. Those of you who live and work in Nigeria know these challenges all too well. There are some critical weaknesses in Nigeria's digital and data systems for healthcare. We know that there is hyperfragmentation and just a proliferation of solutions. Impossible to find a patient and get a complete health record of that patient. We know that digital skills are lacking. We know that connectivity is an issue. And we know that many states have embarked on developing EMRs, but they're not interoperable with each other or with EMRs already in the state itself. We know that as the government has indicated as part of its digital health implementation strategy, that implementation committee that was launched 2 months ago, these are some of the priorities that the government has identified and that Dr. Chris spoke about as well. And so with that, I will hand over back to Olumide to give you a sense of how the World Bank, in partnership with others, hope to be able to contribute to this agenda. Olumide, back to you.
Thank you, Mary-Lise. Thank you. I presume you'll help me move the slides. So I'll just very quickly, to complement what Mary-Lise has just told us about what's happening at a global level, what the situation is with Nigeria today, what do we expect to happen in the coming days? Let's take a step back. I probably apologies if you have heard some of this from Dr. Chris yesterday, but since I wasn't here yesterday, I just felt it's probably important to just remind ourselves where the leadership of the Federal Ministry of Health is today in terms of their reforms. So when Professor Partey and Minister Alausa resumed, they set up what they call the 4-point agenda, which you can see and which I'm sure a lot of people here will be familiar with. Just a few words about that is that there's a particular pillar, unlocking value chains, that's headed by Dr. Abdul Mukhtar and working with private sector entities across board. But I'm highlighting that because for digital in health to be transformative, you would need to engage strongly with the private sector. And I'm not sure that many people in this room or even in the digital in health space are connecting with the Presidential Value Chain Committee headed by Dr. Abdul Mukhtar. Now, those other 3 pillars from governance, quality health system, and health security will be the things that I will somewhat focus on, but they are both interlinked. Next slide, please. So, operationalizing the 4-point agenda, you have what you call the Nigeria Health Sector Renewal Investment Program. This is the name of the reform being implemented by the leadership of the Federal Ministry of Health. in the core, or at its core, is the Basic Healthcare Provision Fund, which is also undergoing some tweaking now. But there are several cross-cutting elements, and I will show you how all of that graphically comes together. But one cross-cutting element there is digital in health. A lot of you might say, what is new? In fact, as I said, in the last 20 years, there's been no program that's been implemented that doesn't have a digital health component. 20 years. But it has not in any way led to any transformational change within the health system. This time, we do hope things will be slightly different. Next slide. Just to show that it's not just all talk, but a lot of things have happened, which led to the signing of a compact by all state governors and Mr. President on 12 December 2023. A lot of people might ask, so what's the point about the compact? The compact is saying, partners, state governments, we will align to one plan, one budget, one result framework. In fact, one data governance framework. It's going to be a different way of working, because USAID, Gates cannot say, I'm going to Yobe, Taraba, Kano. No. On the programmatic side. Even for services, there will be as much effort to collectively agree on a common vision going forward. And it will mean changing behaviors across board. But Dr. Muntaka, whom I think is on the panel, will probably speak a lot more about that. But that swap agenda actually gets more bite in digital in health. Because if we have a common governance framework, we probably will be able to achieve what the banking and financial sector in Nigeria has achieved. Because they've used that kind of governance framework to revolutionize that system. So this is what operationally you would expect in the new reform. The primary goal is really to crash maternal mortality as a key tangible outcome. However, there are many, many parts to it as a way of driving health systems improvement. In summary, you have intense activities going on at the community level, where you have community health workers who are generating demand. You have public PHCs that meet a defined functional criteria. There will be 2 levels of functionality, levels 2 and level 1. Level 2 will be able to take deliveries, unlike level 1, but you must have that level of functionality. At the end of the program, it's expected there will be about 18,000 of such public PHCs. Each of the public PHCs, especially the level 2 public PHC, will be linked compulsorily to a CMONC facility, compulsorily. But not just linked to a CMONC facility, there will be guaranteed transport between that level 2 and the CMONC facility. So, as I said, this is just a short snapshot of what to expect as the basis of the reform. But I needed to show this because there are many, many touch points for digital here. So, for instance, there's going to be thousands of community health workers that are linked to the public PHC, working in a community, but are using digital platforms for either upscaling or giving feedback in terms of results. Within those public PHCs, right now, we generate a lot of data through the NHMIS, but there's no information because it's not coming together in a way that we can use to inform policy. So, the public PHCs are linked, but not just public PHCs, but also to the private operators, to private providers who are within that ecosystem as well. So, including the medical transport. Next slide, please. So, over the last 6 months, partners, Ministry of Health, many stakeholders came together, agreed on that design, but this needs to be funded, isn't it? So a number of partners are putting money together in a pool financing structure. Some who are not going to pool in that structure would align their financing to the program that I've just shown you. The bank is leading the charge on this. So we have received a request from the government of Nigeria to say, yes, if you provide the foundational financing for this, whilst other partners bring in their financing as well. So I'll speak more from the financing that is being operationalized from the World Bank side of things. So we have an operation called the HOPE program. There are 3 components to it, but I'll just describe the Hope Health program, because the Hope Health program directly addresses the design that I've just shown you. It's a $500 million program, but it uses an instrument where government actors across board are tasked with certain responsibilities to say, deliver this result, and then you get reimbursed for that work that you have done. So you get reimbursed after the fact, ex post. If you don't deliver, you don't get the result. Bulk of the operations will be for service delivery. So you deliver X amount of services and then you're rewarded for it. Several people from the States will be familiar with Saving 1 Million Lives, ANRIN, who utilizes this kind of instrument called the Program for Results, P4R. However, there's an element of the operation that is going to be called the traditional project financing. Because having met with colleagues at the Ministry of Health, digital in health is so far, far back that it will probably not make too much sense to try and incentivize an ex-post activity. You are not even sure whether government will release financing that is in the budget. So to guarantee that this is actually delivered, the digital in health component of this operation will be treated as a traditional project arrangement. I'm saying and going into the full details of this because the people who would implement it are in this room. Dr. Ejaudola, Leke Ojewale, Muntaka Umar Sadiq. The World Bank doesn't implement. It is the ministry that implements. And I'm saying this so that states can also begin to engage with them because the monies will sit with them. But in a program for results environment, you also want to be sure that certain things are in place. So we have what we call a prior action. So before you even begin procurement and all of that, we would like to see what the governance arrangement is. What are the standards? And these are critical things because, and that's one of the things my release was saying, that if you're able to have this kind of standards, it doesn't matter who is implementing, it means things can speak to each other. So, and I must acknowledge the amount of work that has happened at the Ministry of Health. For the first time, you have a minister who is leading directly on digital in health. I think the Minister of State Health deserves a round of applause for that, really. Because the reform program has a number of technical working groups. The first technical working group that was inaugurated was the one on digital. And the Minister of State himself is the one chairing that technical working group. In this year's budget at the Ministry of Health, there's an appropriation of almost 15 billion for digital in health. So maybe this is the year where Nigeria's digital in health would really get to that kind of transformational level. But going back to this operation, there will be significant funding available by the Ministry of Health, working with states to define the what, and that Marilise shared, the 3 concentric rings. At the heart of that, we do hope that the Digital Transformation Office will be able to deliver on that, and then stakeholders from within the sector, outside the sector, can innovate around that. That, in my view, will be something that if Nigeria takes advantage of this opportunity, it might make a whole lot of difference. Next slide, please. So this is just simply a summary of what we expect the build out, the kind of things that will be in the build out to be led by the Digital Transformation Office, things around and health information exchange, health analytics, the necessary linkages to health insurance. However, within the what we call the disbursement linked indicators itself, within the service delivery arms of the different of the operation, there are touch points for digital, as I had mentioned earlier. What you have there now is a summary of that. You know, I talked a bit about that earlier on. So, for instance, we're saying that any child that is born will be registered through the CRVS system in a facility, but which is a good thing on its own, but not just registered through the CRVS system, but automatically enrolled into health insurance. With an average of 8 million births per annum, it means that, you know, if you add their mothers to it, you are moving in the region of almost 60 million. And these are the kind of numbers that Nigeria has not experienced before. So I do have I'm optimistic that if we can truly achieve this, then the success of the health reform agenda and the role of digital in health would have come to stay. So I do hope that questions won't be for me. The questions will be for Dr. Ejadiola. Please stand up, let people see you. That is the person you should hold responsible. No, I'm serious, you know, because his office is called the Nigeria Digital in Health Transformation Office. We've not had that before. That's a big reform. Marilise, I know you didn't talk about the Indonesia Digital Transformation Office, but that was the engine room in Indonesia. No, Dr. Ejadiola, because you might need to explain to the audience what that office is doing. That will be the end of my presentation, but please, it will be useful for people to know the role of your office.
Thank you very much, Dr. Olumide. And please, let's give him a round of applause for, because the idea is for us to have uniformity of thinking and idea so that we'll be able to disseminate it accordingly, so everybody can be having the same vision. So what we are looking at is this, is the capacity to change the narrative as far as health service delivery in Nigeria, data-backed health service delivery in Nigeria, so that whoever is making a decision anywhere, anytime, is doing that based on real-time available information that will support whatever decision we are taking. So there are 3 key areas that we have decided to look at. Number 1, the health system, our health facilities in Nigeria, public, private. We need to see how we build their capacity for them to be able to provide service across board using the digital tools that are available. So what we call the intra-electronic medical record at that particular level. So what we are saying is that from entrance to exit, anyone coming in for service delivery, irrespective of where you are coming in, as long as you come to that facility, we'll be able to ensure that using a unique identifier, you are able to navigate all the available service that that particular facility is able to provide for you from the beginning to the end. Now, to do that, and that's the reason why, like he said, in the sector-wide approach that we are looking at is to see how we can bring confidence back into our health system in Nigeria. Because we all are aware that for now, what we see in our facilities is not what we expect to see. And that's the narrative that needs to change. So that is the background, that is the foundation that Digital Health is going to leverage on and provide that positive enablers on as much as possible. So if we are able to do that at the level of the service delivery, the next part is the capacity of all the service delivery to be able to interoperate. So that means that for continuity of service to anyone, wherever you are in Nigeria, you don't need to take all your health records from one place to the other. All you need to do is to go with a unique identifier. When you get there, everything that's been done for you over the years will be right there looking at you, and they can continue treatment as much as possible. Now, the third part is the bigger part that you talk about. We know that our health service intervention in Nigeria goes beyond the facilities. There are a lot of things we do. You mentioned some of them: the community interventions, the emergency preparedness, the vital statistics. All these are also necessary to be able to have a clear understanding of what is it that effort towards providing the right quality care for Nigerians. So we want to create a platform where all these can speak to one another, where everything will be there without having to stop someone or what is already existing. Please, that's the key word. So we need a standard at the level of the facility where every EMR solution speaks to one another. We know it's a very ambitious vision, but if some countries like what we have seen will be able to do it, then that means that it's possible if we all come together and decide to take that particular plunge into that unknown in Nigeria here. And I believe it's possible. So we have that committee set up, okay? Like I used to say humorously, that we cannot bring everybody to the table because we need a very big table to accommodate that. But we have a very big room. So you might not be sitting at the table, but definitely there's a space for you in the room for you to contribute your part into this. So we have this plan for continuous stakeholders engagement. Everybody come in with their own understanding, we'll be able to provide that support to get this done. So the 20-man committee is just to advise the initiator and that particular political will that is now available through the Office of the Honorable Minister of State for Health to see how continue to advise, reaching out to other key stakeholders and continue to bring everything to the table so that at the end of this vision, we can achieve it. And I believe it's something that we can do if we set our mind on it. Thank you very much.
Thank you. So just a quick announcement before we get into the first session, the panel session. If you are the owner of the vehicle, GWA 833AW Abuja, it's a Toyota Corolla LE, ash in color. Please, it's urgent. Please meet one of my colleagues there and they will take you to the hotel. GWA 833AW, ash in color, a Toyota Corolla LE. Thank you.
All right, thank you very much. Yeah. So I think we've had a really insightful session with Dr. Olumide and Marie-Lise. And picking up from where they've left, we are not letting the speed down. We are going to keep the same velocity and frequency. Now, before I proceed, I would like to recognize an individual, a very special guest who is here, Bayo from USAID. Kindly wave up to the... Yeah, when Bayo sings a tune, we dance to it, so hopefully it will also guide us in these sessions moving forward. Yeah, just as rightly mentioned, so I would like to request the mercurial Dr. Olumide back to stage again. Yeah, but now to drive us to the next session. I know we've already started the conversation around the digital in health strategy, right? There's some nuances between digital health and digital in health strategy. We will find that one out from this panel. So in this panel will be led by none other than Olubenga Ijadola, Dr. Olubenga Ijadola, who is the Deputy Director and the National Program Coordinator for the Nigerian Digital in Health Initiative from the Digital Transformation Office of the Honorable Minister for Health. So please clap for him as he comes up. So he will be leading this session and moderating this session, and will be joined by Dr. Anthony. Yeah, he will sit. He can choose wherever he wants to sit. He's the moderator. So, all right. So we'll have Dr. Anthony Odoge. Forgive my French. So Dr. Anthony Odoge is a digital health enthusiast and is currently the Deputy Director and the current Head of M&D in the Federal Ministry of Health. Kindly welcome, Doctor. And then just to join him, we have another esteemed individual by the name of Dr. Leke Ojewale. Dr. Leke Ojewale is a seasoned physician. He has very tough words here, so let me pronounce them very well. Seasoned physician, informatist, with extensive experience in healthcare, public, and health informatics. Kindly welcome him on stage. So last but not least, we have Dr. Sami Adedukun, I don't know if I got that right, who will be joining us, who has agreed to join us in this panel. Dr. Sami is the currently director for BIO Systems Nigeria. And also, Marie-Lise will continue also joining us from the online. We have Marie-Lise who is joining us from online, who is continue joining us from online, yeah. So there's one person I keep forgetting because I work with him every day, so I thought we were going to handle this session with him. That's Oseo Gori, who is the country director for DataFi, so welcome. So I will hand you over to Dr. Jedola for takeover. Thank you.
Okay, all right, good. All right, thank you very much, Evans, for the introduction. And ladies and gentlemen, this is also one important part of this discussion, as much as possible. I'm looking forward to what we'll be gaining from this particular session, because it's really going to help us in moving forward with what we have talked about. We want to appreciate Marie-Lise for giving us that presentation. It set the tone for this discussion, and also Dr. Olumide for also adding value to that. Please forgive us for not being totally gender sensitive in terms of a physical presence. I believe that somebody must take note of that. Please just forgive us on that. We are all Nigerians, and we are all for the same purpose. So, ladies and gentlemen, the World Health Assembly has adopted several resolutions in terms of member states to develop digital health strategy that will contribute to the achievement of the SDG and the UAC in Nigeria. It has been seen as one important tool to be able to achieve this. You also recall that concerning the agenda of the President of the Republic of Nigeria is for us to save life, reduce physical and financial pain, and to produce quality health for Nigeria. And the Digital in Net initiative has been seen as a positive enabler and is a very significant tool for us to achieve that. So what are we looking at is for us to have one common plan, one common tool, one common idea in ensuring that we put everything that is needed to ensure that we achieve that for Nigerians. So I'm not going to waste much time. I'm really going to go down and then create those questions. These questions are just to guide in terms of what we'll be getting from our expert here. If you recall, we have everybody from government, from private sector, from the development and donors, and also be able to have an international expert also joining us online. So it's very key that we do this. We would have loved to have Dr. Mutaka with us to provide more insight into that background that I talked about earlier that need to be in place, or the efforts of the current of Nigeria to improve on our health service delivery, which we believe that Digital will be able to leverage on and be able to optimize as much as possible. But by and large, we will continue to work with that. Thank Dr. Olumide for giving us that presentation that give an idea of what the government is looking at. I think we are well informed now to know the direction the government is taking and for all of us to contribute as much as possible. So I will start with Dr. Olumide, not because you are closer to me, sir, but according to what we have. So what are the important features or critical success factors that we need to put in place for digital transformation to work in Nigeria? Just briefly touch one or two things that we believe that will contribute to this. Over to you, sir.
Thank you very much. In fact, it featured in the slide by Marie-Lise, featured in the slide that I showed as well. Just three things. Three things that I would emphasize. First is leadership and governance. You need to be able to first, and by the way, we got leadership in terms of political leadership, which I would tick now because you have a champion who is leading on it. If you've ever met first you have the minister who is keen on reform and who is keen on making a difference in the broader health sector. But you also then have a minister of state who is a champion for digital in health. So leadership in terms of political, perhaps gives us our greatest opportunity. But there's also the leadership in terms of the people who are here. Dr. Jadeola, people like yourself, Dr. Anthony, directors at the Ministry of Health, directors at the state level. That leadership is key. State commissioners, what do they know and understand about digital in health? That is not just a small portion of a project that we just need to have there just as a placeholder, but people who truly understand and agree that digital in health makes a difference. But there's another aspect of leadership and governance, and that is the financing that you provide for whatever has been adjudged to be a priority. If we do a quick experiment now and do a census of the states in the room, I can assure you that no state in this room, maybe if there's Lagos here, maybe, would have a dedicated line budget for digital in health. Everything digital in health at the state level is financed by partners. Everything. I could almost say that I'm right on that. So that's a part of leadership and governance that seems to be lacking. Even as partners, whilst we're trying to help, we should also rethink the way we're helping. And that's why the SWOP agenda and the ongoing reform will be essential. So that's on one side. On the other side of leadership and governance is the issue of standards. What makes digital in health unique is also the human-centered nature of digital in health. The things around privacy. What are the governance standards around that you are able to protect people's data? Can anybody just access someone's data? So before you deploy anything, you need to make sure that you have the appropriate governance in place. Not just for all of that will be key. The second part of this is people would like to also feel something. So whilst you are, we talk about digital in health, it must be able to deliver services, either in terms of telemedicine, in terms of scheduling appointment. Because if people are not able to make the link between your leadership and governance and how it affects their healthcare, it's almost no work done. So it will be very important that we select one or two services. What is the infrastructure that you put in place? So 3 pillars that I think are foundational, yes. But we always forget that patient side of things. Thank you.
Thank you very much, Dr. Olumide, for pointing that out. Those are the areas that we have really identified, especially the angle of the financial leadership. The signing of the compact, we believe will go a long way to make sure that every level of healthcare in Nigeria contributes significantly to this. So with that, I'll move to Dr. Leke. Dr. Leke, we're together in this. And we are both together in the office of the Minister for the initiative. Where are we in country with regards to the renewal efforts on digital in health? Where are we?
Well, good morning, everyone. So I'm pleased to sort of report that, like Dr. Olumide Okunla said earlier, for the first time in Nigeria, there is a digital in health initiative that is not only created or formed, is actually chaired by the Honorable Minister of State, Dr. Tunji Alausa. So I think that's a very good start. A 20-man committee has been formed, carefully selected by him, and these are folks in private sector, folks in public sector as well, partners, developmental partners as well, that have, and of course experts as well in informatics, that have come together to sort of see how they can drive this initiative. Further along, 4 subcommittees have been created, and the 4 subcommittees sort of speak to what Dr. Okunla has said as well. There is the governance subcommittee, there is the standard and solution subcommittee, there is that infrastructure piece that is very important, and there is that stakeholder engagement, because we cannot achieve anything without engaging the stakeholders, without making sure that the end users are sensitized and they're ready for the change, because change management is a big deal. All right, you're using an Apple phone and then you're switching all the way to a Samsung. You're going from paper record, you're going to now go electronic. We know the level of digital literacy in Nigeria. So the stakeholder engagement is a very, very important piece that we're paying very close attention to as well. So that's how far I think we've gone with the Digital in Health initiative. Thank you.
Thank you very much for that. So all this is towards creating a blueprint that will provide guidance for digital in health in Nigeria. What we are looking at is to have a digital enhanced data-backed decision-making in Nigeria. So the key word here is data. And we all know exactly this has always been the subject of discussions across the country over the years, how to improve on our data for more decision-making. Dr. Tony, you sit in the Ministry of Health as one of your responsibility. So what are the things that we need to take note of best practices in terms of data management and data governance that we need to embrace now that we are moving towards enhancing this with digital health?
Okay, thank you very much. Good morning, everybody. and happy to be here. In terms of data governance, first of all, I would just want to say, I hope we all in the room agree that when we speak about data governance and data management, first of all, data governance is about agreeing on what we need to collect, how we should collect it, when we should collect it, who should collect it, and then what we want to do with the data. Once we agree that that's where we want to go, we set the regulations. That encompasses essentially what data governance is. But a critical part of it would be about the people, about the processes, and then, of course, about the infrastructure and every other thing that we need to be able to manage all of that data. What do the people want? How do the people see their health? And then we can begin to design the processes and then move on to how we want to manage all of that. Which means that we should then be talking about how we would protect, transmit, protect, and ensure security for the health of the people. All that touches on data governance and data management. Now, you ask me what are the best practices. I will tell you, if you look at the global world and countries or health systems that have gotten it right, essentially what they have done is they've been able to put down, like I said, things that will entertain people's data after health provision or during health provision or even before health provision. Put all of this together, protect them, and ensure that the people are happy about them. The processes they've been able to put in place, the people are happy with. The infrastructure and everything that they use and where they want to go even in the future, the people are happy about. So it's always about the people, right? And that starts with number one, health laws. If you go to Canada, if you go to the US, the UK, all across Europe, they have proper health laws that the law around data or data governance is also set within those health laws. Other things that speak to that are the policies, the strategies, and then, of course, the guidelines, and then everybody who work in that space. Now, let's bring it back to Nigeria. Those are the best practices. What have we done here, or what are we doing? Let's see if we are also in tune with those best practices. In Nigeria, we have what we call the National Health Act. The National Health Act establishes the National Health Management Information System. We've done a recent rapid assessment of the data health space, and we saw that over 65% of the people, community of practice, are not aware of what the NHMIS is. And that's a big problem. So you have the enabling laws. You have the enabling policies. We're very good at writing policies. You have the enabling strategies around data. But as you go down the road, especially as you move down the tiers of governance, you see even the awareness begin to wane. Except when you go to places, some states like Lagos, I think the awareness is rising. But that's because it's mostly driven by the private sector. So to answer your question directly, yes, we have adopted some of those best practices. If you see where Nigeria started from, for those who have the story, where Nigeria started from, we were at some point, even in the health sector, rolling without any form of information. But we have made progress. And this is why I disagree with quite a number of persons. We have made a lot of progress. Like I said, we have the laws, we have loads of policies. Sadly, I know this is being transmitted worldwide. Sadly, we don't read. We have loads and loads of policies, and we spend a lot of money reviewing them, and that's not good practice, but it's some form of practice. Like I said, we have moved, we have all these strategies and all that, we have some infrastructure, especially in the private sector. We do have a lot of expertise, again, mostly in the private sector. So moving from data to digital health, whether in terms of provision of care or experience of care, you know, when I hear people talk about digital health, it's mostly around data. But digital health spans even into the provision of care, like Dr. Jadola and Dr. My other panelists have said. So when it comes to the experience of care, data and digital health shouldn't only drive information as per planning or what do we do for the people. It's about the people. It should help them to experience care so that when people walk out of the facilities, they're happy. To say, oh, when I went to that facility, you can see how science were just, those robots were just directing me around, taking me everywhere. Nigerians deserve that. And that's where we want to get to. And all these are driven by data. Now government, federal government is now buying X-ray machines that have PAC system that can speak for themselves, transmit data for themselves. Equipments that can transmit data for themselves. That's digital health in practice. So we have adopted a lot of best practices, especially in the private sector space, but it's how much of it have we taken in? How much of it are we taking in? How much of it are we still willing to take in? Or are we ready to take in? I think I'll stop there. Thank you.
Dr. Tony, thank you very much. If I allow you to continue, that's what we are going to do throughout today, but thank you very much. Opportunity will come again for you to be able to take that. Ote, I have to come to you. I've been with you now for years, and this has always been what you have been doing from when you are all the various stages that you've been. In practical terms, from experience in Nigeria, what do you think are the challenges for digital health in scaling up in country? We just touched one or two things that we believe we need to take into consideration.
All right. Thank you very much, and good morning, everyone, again. I don't know if I will just be able to say one or two things because there are a lot of challenges that we currently face as Nigeria and Nigerians in terms of digital health. Anybody that has been in a digital health space in Nigeria will understand that the challenges are enormous. And some of them have been touched by Anthony and also by Olumide. And Marilis also, where I was laughing with Dauda when she presented on her slide. One of the things about, one of the challenges, and I will start with governance. Governance has been one of the greatest challenges for digital health in Nigeria. But I'm particularly happy about the leadership of the Honorable Minister of State for Health in leading this initiative because it's important to provide leadership in this space and also to ensure that we adhere to these policies and frameworks that are available out there. Interestingly, we have these documents. We have them, and Anthony said it. We have these documents that about 60%, you said, don't even know what is in that document. We have the NIDA document, we have the NDA, the Act, and most people people that work in the digital health space are not even aware of what is contained in it. We have this document for 5 years, but after 2.5 years, we do a midterm review of the document that we don't even know about, or a document that we've not even implemented. So I think that's one of the key things that we have to look at. Then systems governance is also there. There are disparate systems out there. We need to see how these systems speak to each other. We need to have interoperability and ability for the system to be able to exchange data. And I say this all the time. I go to the hospital, I have malaria. The same me will go to that hospital, maybe my BP goes up. And maybe I'm captured by another system. Or you have someone that is HIV positive. Is captured by a system that is supported by a disease program. That person might have TB. The person is captured by another system. That person has malaria. It's captured by another system. If the blood pressure goes up, it's captured by another system. We need to see how we can bring these systems together. And I'm happy that that is what the Ministry of Health is also looking at. Funding and investment. I need to say this quickly. Funding and investment is very key. The government cannot do it alone. And it's important that we have private sector, we have also donor, channel their resources in an initiative that the government is leading and coordinating. Right now, the digital health space in Nigeria is heavily donor funded. And Nigeria, for us to be able to provide the adequate leadership that we need to put money, the government needs to invest in it. And the private sector is there. Huge resources, huge innovation. I think Olumide talked about the banking sector. The banking sector provides a huge pool of resource in terms of financing, in terms of human resources that we can tap into, and other avenues that we can also tap into. So funding is really critical. Governance is really critical. And lastly, you said I should say 2 or 3. Lastly, I want to talk about skilled manpower.
Yeah.
Very, very important. At DataFi, we are currently collaborating with, we started initial discussion with the academia, with the university in Nigeria to see how we can collaborate and build capacity even with the students in the school. So while they are in school, they're engaging with real-life examples like the systems to support and see how we can begin to build a pool of individuals that will come out with examples and real-life experiences and launch one. And they have innovation, they have innovative ideas that we can actually tap into. So that's also an area that we are looking at. Well, right. I think I will stop here.
Yes, because of time. I have to stop. Yes. Yeah. And it's like you have seen my notes somewhere because the last comment you made is one key area that the leadership of the ministry have identified, the Rampeg, the Rando skill set, having the right skill set that is needed across board since we are going toward this light. And some of my colleagues has also mentioned the need for clear knowledge and understanding. So I'll be going to Marilis. Marilis, are you there with us? Hello? Can you hear? Marilis?
I'm here.
Okay, good. Okay.
Hi, Dr. Benga.
Yes, thank you very much. I want you to speak on, thank you very much for your presentation. You talk about a lot of key areas that we need to take note of. But I really want you to speak further on the skill set. What do we need to put in place in terms of capacity building, identification of the right person for the right area for them to be able to provide that quality output. So you've been with a lot of countries from your presentation. So can you provide some light on the skill set that is needed, the kind of capacity building effort that we need to put in place as we move forward with this? Thank you.
Thanks, Dr. Benga. I would say that there are 3 areas that is of immense importance when we... Sorry, I'm hearing myself speak. There's quite bad feedback, so apologies if I'm sounding somewhat broken up. 3 areas that are really important. The first is what we would call foundational digital skills. And foundational digital skills means just the ability for any person in the population to feel comfortable with digital technology, to be able to interact with an application, to know what is a QR code, for example, to know what a digital ID means, to know what it means to send a medical record or receive a document, and to trust if there is imagine a future where every Nigerian has a mobile app on their phone as they do in Indonesia, and a person's full medical record from the day that they were born, immunizations, all the medical care that they've received throughout their life is stored, it's not stored, but is available for viewing on this one mobile app. We need for people to feel comfortable with that data, to trust that that data is safe. And so that's the first level of skill that is needed. The second level that is needed is a dedicated cadre of medical med tech technicians who can work in the health sector at health facilities and be responsible for data and digital technology. I think too often we expect doctors and nurses to take on this extra burden of digitalization. Here in Indonesia, we even heard earlier in the week that some doctors and nurses are helping patients create email addresses and the things that they need to interact with the mobile applications that the government has made available. In fact, we went to 2 hospitals earlier in the week where the hospital director was telling us that her staff spends about half of their day every day just filling out electronic databases because it takes a lot of time to do that. We need that time of doctors and nurses to be freed up and for there to be dedicated people with the right skill sets who can interact with digital and data technology. And then finally, we need the high-level experts. We need well-trained IT and ICT staff. Part of this middle layer that I described earlier is also that doctors and nurses need to understand digital technology, feel comfortable with it. I believe it needs to be part of pre-service training in the future, but so that they can use digital technology and data as consumers, not as the ones who operate those systems. And so those are the 3 types of skills that we have seen that is essential, and not just training doctors and nurses, because I think sometimes in the health sector, when we think about digital skills, we think about reskilling folks who are already in the system. And there's definitely a level of that is required, but I'm suggesting there's a wider lens that we need to look at for digital skills. We need to look at patients and their level of comfort, and we need to look at the higher level skills as well. Thank you.
All right, thank you, Mary-Liz, for that insight. We're really grateful to that. Yes, Sami, one of the key aspects of Dr. Olumide's presentation and Mary-Liz is the area of private sector. Where would they come in this? What support do they expect to bring on board? Now, one way or the other, currently working with a setting like that. So what do you think? Something that we need to take note of in terms of private sector's intervention.
All right. Good morning, everybody, and thank you, Dr. Ijadola. I think so much has been said about the fact that right now, most of the investments in the digital health space in Nigeria has come from donor-funded projects. And I would like to say that in itself is private sector driven. And the strength of the private sector is the fact that when they put their money into something, they monitor it to ensure that there are results. And then when you go to the core private sector, those into providing the infrastructure, the telecoms companies, and all those, you see that they are the ones that brought in the resources. And I dare say that if you want to have a digital in health strategy that is functional, you need to deal with the infrastructure side of things. So one of the first things we need to do is to get that private sector investment in infrastructure to be in place. For example, you have a health facility, a PHC, somewhere in Riverine, Bayelsa. You don't even have internet penetration at that level. So as we begin to talk within the health space, we need to begin to talk to the sector that is responsible for ensuring that the infrastructure is in place to align their strategies and their scale-up plans with what we want to do, so that we know that the digital gateway that is available can sustain the services that we want to provide. And then going back to the donor angle, we know that there's a lot of expertise in the donor-funded projects. And so one of the things we can get is to bring them to the table to advise on how we want to go about implementing this digital health strategy. And I think this kind of forum is actually in order because we're doing a lot of sensitization, talking, everybody is getting to understand the direction the government is going, but we need to bring those experts on board to advise on how to go about it while the government takes leadership of actually governing the entire process.
All right, thank you very much, Somin. The challenge is time is not really on our side. I was told that there are lots of questions online, and also, I believe, interesting question from the audience inside the room. But, Marilis, I have to come to you quickly, okay, before we move towards the closing parts of this session. Patient-level information protection. From your experience with other countries, what are the things that we need to take note of in terms of protecting our data? Because we'll be working much with patient-level data, and it's important that we put in place the right measure to ensure that these data are not for public consumption. So what can you provide as a form of an insight into that? Quickly, in 1 minute, if you can.
Dr. Bringa, I would just say that there have been several efforts to help countries develop legislation in this regard, and I do believe that Nigeria has a personal data protection law, but to supplement that, often legislation and regulations are needed. There are model laws and model regulations that are in place for countries to learn from, and I think that it would be important and relevant and useful for Nigeria to look at those. In essence, we need to find the balance between protection and also sharing for public good purposes, anonymized, de-identified data. And what is key to all of that is patient consent. Both patient and provider consent is absolutely critical when we talk about protection of personal data for health purposes. Thank you.
All right, thank you very much, Marilis, for that quick response. Evans, I think we will just go for like 2 questions.
Exactly.
And what I just want to say is that the rest of the question will be part of the output of this meeting. We are looking forward to that, to see the report, a technical report that will include those direct questions so that we can look at them and see where we can also continue to work with them. So quickly, let's have those just 2 questions.
Yeah, exactly. So I think this panel is, since we started, has elicited a lot of questions. So we have like 15 questions, which we won't ask all of them. But I'll just pick one, then we'll let the crowd, 2 more questions from the crowd. So the question that is of interest, which is repetitive here, is around hope financing. So they're asking, how is hope financing different from other past ongoing performance-based financing models that have not stimulated government investment in health, both at the national and subnational level? So that is the major question that is coming out. So maybe that is the one I'll channel to this, then we'll pick 2 more questions from the panel.
Right. Dr. Lumide.
Yeah.
I have to.
Okay. So, yeah.
Okay, just take note of that. Let's have the second one quickly.
All right.
Yes.
So we
online, are we taking only one from online?
So online, there are 15, and I've picked one.
Thank you very much. So let's
I
have
will let
one or
Dr.
two
Ladu
from the
have
audience.
this one
Please
more.
introduce yourself.
Okay, thank you. Good morning, everyone. My name is Dr. Iladu Okwamade from NCDC, and we've been working closely on digital for health initiatives. So my interest is around data governance. When Dr. Tony was talking about data governance, yes, we have a lot of law already and policies in place, but how much of this has been translated into action in terms of ensuring that Nigeria has what we call a digital catalog or have a national warehouse? And I know that is the essence of the initiative. So in terms of the nation, how much have we moved to ensure that that is achieved? And what is the timeline so that we'll have a data warehouse as a country where we'll pull all our data together? We know that currently, despite a lot of laws and policies, we still have data silos in different organizations and different agencies. NCDC is talking about interoperability, but the interoperability doesn't still include data like malaria, HIV, and TB. So how long are we going to ensure that this is achieved? Thank you.
Thank you very much. That's noted.
So one more question. I was hoping for gender balance, but yeah.
Thank you. My name is Dr. Adamu Usman, Bingham University, Faculty of Computing. Data is a very interesting thing. And when it comes to data analytics, one of the things or challenges we've had when dealing with medical science is how do you, for lack of a better way to put it, how do you handle incriminating data? I'm going to take it from this perspective, okay? Medical science, there are two sides to it. Some hospitals, I've had situations, we've seen people with situations where you go to one hospital and they refuse to share your medical data for you to take to another hospital. Now, from your perspective of policies, are hospitals going to be mandated to join this system? Because if not, we're going to have a lot of gaps. A lot of people are going to hide their data because they don't want to be incriminated. So these are issues that are real and on the ground for the Nigerian. So I think, how do we handle that? I think just to kind of have another perspective on this, what do we do with ownership? Does ownership now become public? Does that mean that people cannot own their data? Who owns medical data in this particular situation?
Thank you. I think you can take that.
All right, good. Okay, so we have like 3 questions. We talk about co-financing. Dr. Olumide will be speaking to that. Between Tony and Ike, let's have what are we doing concerning the data architecture that we're planning. That's speaking to one another as much as possible, which is the end goal, actually, of the Digital Net Initiative, is to see where we have that linkage in terms of data. So they will be speaking a little more on that. Data sharing. Actually, it's the responsibility of the government to answer that, but I will push that to Otse to say a word, then we round up with either Tony or Leke to also speak on that. So, Ms. Fokin?
Did you say
co-financing? Is co-financing. Yeah, co-financing.
H-O-P-E. H-O-P. Oh, okay. All right, thank you. I just needed to be sure about that. What's new, what's different about the financing under the HOPE operation? What's new is the swap compact signed on 12 December 2023, signed by 36 state governors, most of the development partners in Nigeria, and Mr. President, all aligning behind a common framework. And what's happening now is that monies from partners, for example, not that it's enough, but if it's pooled within one larger framework, the kind of hyperfragmentation that we see reduces from day one. It then means, for example, also using your example, you launched the information systems for the public health AOC in Edo State. If there's a common standard for that platform, if FCDO comes, if GIZ comes, everybody is financing one standard. So even if financing doesn't come through HOPE, you are financing a common arrangement. So it's not that there's a call for proposal that is doing something that somebody somewhere thinks he wants to do. Here, you are financing a plan, a framework that has been commonly and uniformly agreed by everyone. So the financing coming from HOPE is the first set of financing that does that. And you already have FCDO, a number of philanthropies, Children's Investment Foundation Fund, all of this financing through the World Bank, through the HOPE operation. Some will not be coming through the World Bank. It will be parallel financing, but we would all be financing a common framework. So there will not be the idea of some partners going to some states and doing what they like. Rather, we're going to come through a common arrangement so there will be no orphan states. So it's a kind of rearrangement, it's a kind of realignment behind a common goal. And the financing through hope is the first step in actualizing that vision.
Thank you very much, Dr. Olumide, for that. So we need to move on quickly. One common data architecture that will be able to speak to everything that we put in place in terms of interventions and services in Nigeria. Dr. Tuni, what do we need to put in place? One more thing, you mentioned some. What other thing do you think we need to ensure that it's there?
Okay, thank you very much, Doctor from NCDC. I'm just going to take both questions together so you don't have to come back to me. Yes, what we currently see in the space, I think there have been fundamental errors made, different platforms, operating systems set up. And I hear people talk about interoperability, sometimes even confuse it with integration and all of that. But what really needs to happen is, at the center here, when talking about data interoperability, we need at this point now where we are to set up a data center. You know, either setting up one for the health sector or co-locating with one that's already existing, but we have gotten to that point so that we are better able to manage patient-level data. Now, in terms of data security and all of that, privacy, the patient, number one, owns the data. After the patient or the client, it's the Honorable Minister, period. Now, that transfer of data between systems, it's something we really have to look at critically. I remember when I was back in the UK, they were still struggling with this. Because what happens is if there's a breach, it's the Honorable Minister that will be sued. So it's something we still have to look at critically. How do we achieve that data transfer? Technology has gone very far, and I think if we leverage on the expertise that we have in-house, and I'm sorry to say to a lot of our vendors, you know, who are not in country, that this is the reason why you see us pushing back when you say, come, let's do some business. It's because anywhere in the world, government has to keep patient data, client data in-house. As much as possible, we have to ensure that we do everything within our power. Thanks to NIDA, thanks to SON, you know, they've provided that. We are leveraging on all those laws to ensure that that data transfer breach will not happen. And I'm sure with the committee and ongoing talks, we will ensure that we continue to protect the data of all Nigerians.
Yeah.
Thank you.
Thank you, Dr. Tony. Dr. Leke, one of the subcommittee set up by the Honorable Minister under the Digital Inet Initiative is the governance, regulatory, and the cyber security. What should we be expecting from that in line with the data protection angle?
So in a nutshell, so data protection is a big deal. All right, I do not want my protected health information in the hands of the public, like someone said earlier. So the goal of the governance subcommittee is not only to just come up with, this is how things should look. We're going to take it a notch further to see how much we can pass, how much laws we can actually pass, you know, to say that the healthcare provider is not allowed to release this data, you're allowed to release these, you're allowed to exchange these, following 1, 2, 3 tier standards that we put in place for all and every EMR that is going to exist in the country. Thank you.
All right, thank you very much. Like we said, we need to close now quickly. And gentlemen, thank you very much for your insight into this, but I will close with this. And I want you to, in 1 minute, tell us what you want to see in 3 years' time. What do you want to see as far as digital health is concerned in the next 3 years? Dr. Olumide, to start with you.
Just where I can, with my mobile phone, access my health record, make an appointment to see a doctor, all on my phone in this country.
Thank you. Tony?
Well, for me, it's all about the people always. I want this, in 3 years' time, I want anyone in the country to be able to come out from even the smallest space here and say, wow, what just happened what just happened when I walked in there to receive care? You know, that's what I want to see. I mean, it's a lot, but that's what I want to see. Thank you.
Leke.
So I also want to see a widespread adoption of EMR, acceptance, buy-in from all end users. Thank you.
Somi?
A well-articulated roadmap for the digital health in Nigeria that spans beyond 3 years, a mapped out financing structure to actualize it, and then baby steps in terms of implementation. I would not expect total coverage of the entire country in 3 years, but I like to see that roadmap is being implemented and can go on beyond 3 years. Thank you.
Ose?
It's always not so good to be the last person because everybody has said everything. But I think for me, it's critical that what the government is currently doing, there is a sustained momentum. It's usually what happens in government is that an initiative like this starts, then 2-3 years down the line, everything drops. But I want to see a sustained momentum, and we see integration of all the systems that we have in country, so that when a patient walks into a facility and we collect that person's information once, we know we've collected it once, and it can be shared across system, taking into consideration what Dr. Adamu said, privacy, security, standards are in place that ensure that this happens. Thank you.
Okay. But last not the least, Marilis? Marilis? Is she still on? Marilis, what do you want to see in Nigeria in the next 3 years on Digital Net Initiative? Are you with us, Marilis?
Yes, I am. Can you hear him?
Yeah, we can hear you clearly. Did you get the poster? Did you get the question? I just want to know what do you want to see in the next 3 years in Nigeria?
Health workers thanking the ministry for how digital has made their lives easier. Health workers explaining how it's saving them time, it's saving them energy, and that they can spend more time with patients. Because without these incentives and the people who use these systems day in and day out, no longer complaining that it's taking time away from patients, but it's helping them to do better with patients. That's where we need to focus our attention.
Thank you very much. Ladies and gentlemen, you agree with me, it has been a very interesting session, but we just have to close here. And I want to appreciate everyone. I also apologize to all the questions that are online that we are not able to attend to, but be rest assured that all this will be taken note of. We will consider that when we get the outputs of these 2 days engagement. Gentlemen, thank you very much for having your input. And please, let's give everyone a round of applause. And thank you.
Thank you very much. Thank you.
So over to you, Evans.
Please, another round of applause for that wonderful panel session. We must confess that was really insightful and thought-provoking. And we can only hope that all these dreams you have would one day be actualized. That's the essence of these panel sessions that we have to stimulate us to want to do better and even want to do more. So while we had the panel session, we had some important guests come in, and we just want to quickly recognize them. So we had Dr. Ganiyu Jamiu. He's the National Chief Epidemiologist from the Federal Ministry of Health. Please, can you wave? You're welcome, sir. Please, with a round of applause, let's welcome him. We also had Dr. Okunromade Oyaledon, HOD Surveillance, and apologies for the pronunciation. HOD Surveillance, NCDC. Please, with a round of applause. We also had Dr. Homsuk Swomen from USAID. Apologies once again to Swomen from USAID. Round of applause. And we had Dr. Olubenga Asaolu, also from USAID. Please, a round of applause for him. So we also want to continue with the same momentum. So the next speaker who will be coming up will be having a conversation around Integrated Health Emergency Operations Center, an effective coordination mechanism for emergency response in Nigeria. And we also have a powerful person who will be coming on to take on this topic. He's a consultant public health physician and a fellow of the West African College of Physicians and National Postgraduate Medical College of Nigeria. He's also a deputy director who oversees the National Viral Hepatitis Control and the National HIV/AIDS Viral Hepatitis and STI Control Program for the Federal Ministry of Health in Nigeria. Please, if your hand is not busy, and with a warm round of applause, can we kindly welcome Dr. Ganiyu Jamiu to the stage to give us his presentation.
Good morning, ladies and gentlemen. Actually, I will be making a presentation on what we've been able to do so far regarding Public Health Emergency Operational Center. Year in, year out, Nigeria is challenged with different outbreaks, public health emergencies. Just this year alone, we've recorded cerebrospinal meningitis in Gombe State and currently in Yobe State. And also, we are now faced with the bigger one at the moment, heavy metal poisoning and toxicity, which is currently going in Sokoto State and Zamfara State. And all this require a more coordinated and integrated response. And that is why we felt, in line with the vision and mandate of both the past immediate Honorable Minister of Health and the current Minister of Health, there is need for us to strengthen our health security system, which encompasses the surveillance, the aspect of antimicrobial resistance, the emergency medical response, as well as laboratory networking. In line with this mandate, in order to further strengthen our emergency operational centers, Datafy, in collaboration with Federal Ministry of Health, decided to embark on a journey which requires that we carry out assessment of our emergency operational center. We are all aware that in all states, there are different levels of functions, structure regarding emergency operational center. But what we intend to do is to make sure that we make them more functional, more coordinated, so that we can respond to both emerging and re-emerging diseases. And that is what informs what I'm trying to share with us here. So as part of my introduction, which I've just said earlier on, you all agree with me that public health emergencies are extraordinary events which require coordinated response. At times, it even requires international collaboration to ensure that we responded effectively to every emergency threat. COVID-19 is an example of what happened, which many of us are living witness to that. So it is not new to us. So we need to, move to the next level to ensure that whenever we are confronted with any form of outbreak, we're able to actually respond, plan, respond, and recover as soon as possible. So in line with my presentation, as I've said, currently we have different emergency operational centers at different levels in the 36 states and FCT. And on this, thank you. So they all operate at different levels. Some have gone higher, where some are still at a very lower level. What I mean by that is that the functionality of some is reactive, meaning that there is no structural structure that would demarcate as EOC. It is only when there is an outbreak that they just come on board, they don't mobilize themselves and so on. And that's not the way we want to go. We want to have a structure in which, whether there is an outbreak, whether there is an emergency, there are people there to perform the work. And that is the direction we intend to go. And also, looking at the fact that there are different levels of functionality, there is need for us to harmonize. And that's one of the reasons that inform the need to carry out this assessment. And in doing that, the Federal Ministry of Health, in collaboration with NCDC and Datafy, decided to conduct an assessment. The assessment actually started about 2 years ago, but we were able to conclude that in February 2024. And what happened was that at the initial phase, we were able to assess 3 states and FCT. Along the line, sometimes in February, we're able to conclude that, which we are very happy about, to actually share the findings of this assessment. And the goal of the assessment, as I've said earlier, is wanted to identify the functions and structure of EOCs so as to guide our implementation towards integrated approach to EOC. We don't want polio EOC, malaria, we just want everything to be one so that we have one command structure operating together so that we can effectively and efficiently control whatever emergency threat that come on board. And also, based on the objectives of the assessment, we identify coordination and infrastructural gaps, which we'll be able to do. And also, based on these findings, we also intend to develop an implementation plan with a clear roadmap for strengthening and integrating existing emergency operational center across all the states. And also, in line with our findings, we also plan to design a capacity strengthening plan, resource mobilization, and sustainability plan for the integration of EOC. Those are our key objectives of the assessment. So what are the methodology that we adapted? The locations are all the states and FCT. Then we look at 7 thematic areas, and this included governance and coordination. We all know the importance of governance and coordination. Without it, there will be haphazard response to emergency threats. So we need to look at that. We look at planning and procedures. We look at information communication technology. We look at information system and data standards. We look at the operations at the EOCs. The human resource capacity, we also look at that. And also we look at training and exercise. What are the available training opportunities and so on. And those are the areas we look at. And in terms of data collection, we use a checklist which was adapted to cover some of these 7 thematic areas. And the collection, the period for collection of the data was about 3 months, when data analysis was 3 weeks. And what we use in our collection, in data collection, we use both qualitative and quantitative approach. And in our analysis, we use simple Excel for the quantitative when we use thematic analysis for the qualitative. And as I've said earlier, the team comprised of 3 organizations, which I've mentioned earlier. Our findings, as I've said, based on these 7 thematic areas, we look at we're able to identify the fact that states function at different levels. And also, based on these 7 core competencies, we're able to identify that many of them have them in place. But in terms of operation, it varies from one state to the other. And also, based on this categorization, we're able to categorize states into 3 capacity levels to determine their requirement need to be able to achieve that integrated approach. And in terms of capacity level, we're able to we base that categorization based on a scoring method. And in that method, we're able to allocate 1 for every questions or variable. And for capacity 1, we look at these are states that require just some minimal effort to be able to read that minimal standard that is required. And looking at that, we have different components, which I don't want to list, but it's based on that 7 thematic areas. Looking at area of ICT, computer workstations, whether the toll number is efficient, whether they have it in place, is it actually working, and so on. And in terms of categorization, we rated those people that belong to capacity level 1 as having a score of 71 to 100%. And in this, Anambra, Benue, Borno, Ekiti, Gombe, Kano, and Katsina will happen to be in this category. And one thing I want to say, it does not mean that the requirements of all these states as I mentioned is same. Some, the challenge may be that of workstation, some may be issue of ICT. So that's why the fact that they belong to that same level, capacity level 1, their need varies. And that is how it is in all the capacity level. For the capacity level 2, they need some more effort compared to 1. And as I've said earlier, the needs based on individual states varies from one state to the other. And I've mentioned earlier, the requirement also depends on the need and requirement at state. And some of the states that belong to this category include Abia, Adamawa, Akwa Ibom, Bauchi, Bayelsa, Cross River, Delta, Ebonyi, Edo, FCT, and so on, as highlighted on my slide. Also, for capacity 3, these are people that need most of the resources. And you can see their grade is between 0% to 35%. And you can see we have states like Enugu, Jigawa, Oyo, Plateau, Kaduna, and Taraba. As I've said, the need may still varies across states in a different capacity level. So what are the mandates for a harmonized approach? We ride on the fact that Federal Ministry of Health core mandate is to see that we link, integrate, and coordinate processes for effective response to all health emergencies, disasters, and so on. And that's what really bothers us at the national level, and I want to believe that also at the state level. And we also ride on the vision of the Honorable Minister of Health, which emphasizes on the need to strengthen health emergency management capacity and emergency coordination mechanism at all levels. And we also have a policy that actually stated that, and that is based on the National Health Policy of 2016. Also, what are other justifications to warrant why we need to adapt integrated approach to our emergency operational center? We look at what? The need to integrate all health emergency and disaster risk management programs into national or subnational health plans. Not that we have fragmented EOCs and so on. And that will help, apart from ensuring effectiveness, it will also ensure efficiency, because through parallel program, there will be a lot of wastages, and we want to see as much as possible how we can reduce such wastage. Also, the need to institutionalize capacities for coordinated health and multi-sectoral action to assess risks as well as to proactively reduce risk. Also, the need for us to prepare, respond to, and recover from all emergencies, disaster, and other crises. And this will require strengthening collaboration and ensure coherence and complementarity of actions with those of relevant entities, and including those in public, private, non-governmental. One thing I want to believe is that, irrespective of whether you are from the government, you are coming from MDAs, or you are coming from the private sectors, everybody will come together to ensure that we all collaborate to achieve appropriate emergency response. Also, to support country and community health emergencies and disaster risk management, which include disaster risk reduction, as well as ongoing effort by member states to implement international air regulation. We are all key into Nigeria. It's one of the signatory to international health regulation in terms of ensuring that we secure prevent international spread of diseases in such a way that it does not interfere with trade, tourism, and so on. And also, our approach on integration is also right in the fact that FOMA will adapt a national health system approach, specifically as stated in our National Health Act, that the Federal Ministry of Health shall ensure the continuous monitoring, evaluation, and analysis of health status and performance of function of all aspects of national health system, in order to promote a spirit of cooperation and shared responsibility among all providers of health services in the Federation and any part thereof. So, what are the key principles? Yes, there must be what? Coordination at federal and at subnational. That is what we want to. So that when you go to any state, not that the NEMA or the representative of NEMA are doing their own, polio is doing their own, and every other else is. We want an integrated approach. Everybody will work as a team, and that is what is our vision regarding this assessment, regarding this assignment that we are currently carrying out. And also, we want a situation where it will be state-led implementation. I want to tell us that we've started it all now. Some of the outbreaks I just mentioned earlier on were being led by the states. It's just that every other stakeholder come on board. Unlike those days that whenever there is an outbreak, you see national or everybody from NCD move. No. the state's capacity have been so built to a certain level that they can actually, respond. It's only that when such kind of situation, especially disaster, overwhelm them, that we may need a kind of support from the national and other relevant stakeholders. So our approach is to ensure that the states lead every implementation regarding this. And also, as I've mentioned earlier, integrated processes and systems, and that is what we'll be advocating for. And I want to believe we can achieve that. Currently, it's happening in some states. Lagos State, example, where it is not being operational. It is our dream. We are driving the process to make sure that we achieve that in that place. And streamlined communication pathways, very important. You could see that during COVID-19. Not that when there's an outbreak, and one agency will pass this information, another will do that. There should be one chain of command. So that if there are, especially, and we all agree with me that during emergencies, there are usually myths and misconceptions. So there will be people, the risk communication people will be there. They will get information for all the relevant pillars and they'll be able to pass appropriate information. We don't want a kind of haphazard kind of coordination of emergency response. And also, we are not reinventing the wheel. What we are doing is that we are leveraging on an existing structure. We have the structure already. What we are just trying to do is to see how we can strengthen it. And that is why we decided to carry out the assessment, look at the gaps, and see how we can help the states directly and indirectly to be able to get to the level we think they can actually respond to emergencies. So what are the structures we are looking at? We are looking at the Honorable Minister of Health, which is the chair. We have a steering committee which the minister communicates with. We have the departments, MDAs, Ministry of Health, department, agencies, which they link directly with the minister. Then at the coordinating level, we have the DPH. At that point, we are supposed to have a technical working group that will also guide in policy making, in every other thing, guideline review and so on. That is why under the technical working group, which many of us are familiar with, we are going to have subcommittees on policy and guideline. We are going to have on advocacy, resource mobilization. We are going to have a supply chain and lab, monitoring and evaluation, and as the need arises, we have different subcommittees. And also, at that level again, we are going to, and the secretariat is expected to be feeding back with the DP, Director of Public Health. Then we now have what? The manager itself. Under that, we now have our operational unit, logistic unit, safety, security, and other pillars as the need arises. So what are the key next steps? We intend to disseminate the state's assessment, the report of this assessment. Many states are very, very important. They are interested in the outcome of this assessment. For instance, Lagos State, the commissioner has been calling me one day because they are so interested. Because the key thing is that we need to strengthen air security so that we can respond. Whether we like it or not, we are battle with emerging and emergencies. Emerging and emerging diseases, and there is it for us to prepare ourselves towards ensuring that when they come, we should be able to respond appropriately. Look at that, the heavy metal poison I just mentioned. Those days it is lead. Now we now have individual having toxicity for three heavy metals: cadmium, cobalt, lead, and so on. So it's really not funny. And what you want to know is that, especially the heavy metal poison that we are now, we had it before. The first case was in 2010 in Zamfara, then 2015 Niger. Those are minor cases. Now we're having more cases, and it's getting more complicated. As I speak to you, I don't think we have a national lab that can actually carry out heavy metal toxicity testing. We ride on UCH and other private labs. I don't think these are areas we need to look in and see how we can plan ahead so that when such kind of emergencies occur in the nearest future. And finally, to conduct an orientation for core stakeholders and state steering committee from all the 36 states to get their buy-in on the concept of integrated approach and the function of EOCs, including the expected rules and responsibilities. Thank you very much for listening.
Please, another round of applause for him. Thank you so much, sir, for that wonderful presentation. So I know we have questions, but before we go into the questions, we have a mini presentation, I would say. We'll have some words from the country director, Otsel Gori. Please, let's usher him with a round of applause.
Thank you very much. Thank you very much. So earlier when I spoke this morning, before I come to Dr. Ganiyu, and Dr. Ganiyu, thank you very much for that presentation. I wanted to tell you that Edo State has gone ahead of Lagos State, but we'll talk about that later. Earlier when I made the welcome, I missed one of our key partners, which is Bingham University, Dr. Adamu Usman. Dr. Adelaye, he was here. I think he stepped out now. I spoke about the collaboration with the academia, where we are trying to work to build capacity of in-school computer scientists and health informatics experts. We are currently engaging with them to take that discussion forward. So thank you very much for coming. It's great to collaborate with you. I didn't also mention our senior regional manager. I'm sure you guys saw him yesterday, Dr. Dauda, who flew all the way to be here. He's very jet lagged, but he's trying to keep up with everything. Thank you for coming. NCDC, Dr. Ladun, thank you for joining us. I know Dr. Oladejo was here yesterday. I watched online when he was here. And also to the DPH, thank you for coming. I don't see any other government parastatal here. Thank you very much for coming in case I missed you. I've thanked the states earlier. Then USCDC, Dr. Notu is also here. Thank you for coming. And I will not go down without saying thank you to USAID. You know, they are the big people that hold the money. So I must say thank you to them. Thank you very much for coming. They are highly and heavily represented here. And I believe you're enjoying the session. So I'll go to the next, before we see the video, while Dr. Ganiyu was speaking, he spoke about state-led implementation. So there was this assessment that was done. And the findings from this assessment, we engaged the Department of Public Health and the Ministry of Health at the state level. And some of the states started running with this idea. An example is Lagos State, which he mentioned. But one critical example is also Edo State. Edo State, with the leadership of His Excellency, the Governor of Edo State, Governor Obaseki, they've come together to put in place an integrated public health emergency operations center. And the interesting thing about this center is that it's a collaboration between all the parties. So there are equipment there that is funded, or even activities funded through USAID. There are other activities funded through PEPFAR. There are activities funded through NCDC. There are activities funded through NACA in the same facility. So we are leveraging resources for better health outcomes. We are maximizing our resources. And it's really interesting what is happening in that place. We'll watch a 2-minute video. And once we are done with a 2-minute video, Dr. Stevenson will just come to the stage, and I think he will sit down too so that they will ask you some questions. He will just tell us about their Edo State journey, what they did to achieve that. I won't say much. We'll watch the video and then we can ask our questions. So thank you very much.
Edo State Integrated Public Health Emergency Operations Center, the very first in all Nigeria, opened by His Excellency Mr. the Executive Governor of Edo State, commissioned for use on May 21st, 2024, by William D. Stevens, the Consul General of the U.S. Consulate.
The Edo State government wishes to express gratitude again to USAID, Data FI, for the support given to the state over the years in improving the health of the residents. However, we believe that through your support, Data for Data FI and other emergency partners, we will continue to ensure sustainability of this institution. It is our hope that through your continuous support to the capacity of our healthcare workers, we will be able to strengthen our healthcare system development and then increase service delivery to reduce public health disease outbreaks.
To where we are today, where we have an integrated emergency operating center for public health response across the entire state and the entire region. And it's something that I think speaks to the incredible work of Niger's partners.
I want to present our works as an contribution and support to the public health system.
First, I want to say thank you to your excellency. It's amazing the relationship with the state. It's amazing the work of the state. It's actually cascading down to the other commission and also to the PhDs who have worked very closely. So I want to say thank you for the relationship and for the work of the system. Then I want to say thank you to my father and also to say thank you to the Consul General of the state. Thank you very much for you. It's a pleasure having you here.
Yeah, it's exciting to see how much great work is being done across all the states in Nigeria. It's applaudable. Well done, DataFi. So I think we can take our questions now. We'll just interact with the audience. If anybody has a Okay. So we would have a few words from the DPH Edo State, Dr. Stevens. You can please come up. Please, a round of applause, please.
Good morning, everyone. I am pleased to be invited to share some light on what was just presented. It was a rigorous journey, and I'm happy with the support of DataFi and my executive governor in collaboration with the commissioner. We are here today and we have achieved our aim. It was sometime last year when the Federal Ministry of Health came to assess our EOC. In the same vein, they presented to the state that they want to also establish the EBS Center, that is Event-Based Surveillance Center, and they needed a space. We already have an existing EOC, Public Health Emergency Operations Center, where COVID data will be analyzed. And before then, we all know that Edo State is known for Lassa fever endemicity. We're also trying to analyze our data with regards to Lassa fever in our Public Health Emergency Operations Center. DataFi have always been there for us. They help us for our situation rooms, and we hold our PHEOC meeting every Friday, which they sponsor, and we analyze our data, and we use it to inform policies and progress. So we operate One Health approach. In our EOC, we have One Health approach, which brings together various ministries, Ministry of Health, Environment, Agric, local government, information, needs to ensure that we put together all the stakeholders, in analyzing our health situations in Edo State. So the Honorable Commissioner invited me for a meeting. He said, now these people are here. What do you want to do with them? He said they need a space for event-based surveillance system. We already have an existing EOC. I then suggested that we need to pull this together. We need to have them under one roof, where we can operate seamlessly and bring out our facts to the table. There was an existing building which was accommodating the PHEOC. I took the team there from Federal Ministry of Health, but there was an adequate space that would accommodate the equipment that were brought in. NACA was very helpful. I don't know if anyone from NACA is here. They also supply us some equipment to support the PHEOC. DataFi are here. They provide a lot of gadgets for the functionality of the PHEOC. And pulling all together in that small building was not too good. And I was made to bring up a memo to His Excellency requesting for an adequate space for a PHEOC. The governor responded that you already have an existing one. And I was invited to defend my ask. And I was able to put on the table that there are some equipment for event-based surveillance system, and we have existing PHEOC, and the immunization in the Primary Healthcare Development Agency is on. We harness data from immunization. There was a tool developed by DataFi, which we use in monitoring immunization progress, and that is on there, and the data always hit the dashboard at the EOC. There was need for us to harness all this together in one house. And that was where I came up with the concept of the integrated public health emergency operations center, which I discovered with DataFi, and we have to drive the force. His Excellency was graciously approved what you saw. For us, is in the state secretariat, and he has to give us one floor, and that's the ground floor to be precise. And we now have an adequate accommodation. We have to drive the force, and that was why we have to vacate our PHEOC, the old one now. This way, we invited NACA and Federal Ministry of Health to come and install the event-based surveillance. The first hall they enter that is the event-based surveillance center. The other one is the EOC. Everything is in there. The most interesting thing is that DataFi have been very helpful. They have also been able to establish for us the HIV situation room, which is also in the AOC. So, immunization data, HIV data, Lassa data, COVID data, monkeypox, diphtheria, all data are housed in Public Health Emergency Center in Edo State. And it was launched on Tuesday, and it was so wonderful. We are right there. Edo State is a reference point as we speak. When the national epidemiologist was giving a speech, I was looking at the data. I know that that same slide was presented to us, the Director of Public Health, when we had a meeting in Lagos last year. And we were at that level 2, but we are no longer at level 2. We've surpassed level 2. I think we've surpassed level 2. So I will graciously invite the National Federal Ministry of Health and NCDs to come and reassess us and place us rightly. Thank you.
Thank you so much, sir. I'm sure the necessary assessments will be done. A round of applause once again to the DPH Edo State. So we will take questions now. So if you have questions, please, you can just identify yourself by raising up your hand so that the person with the mic comes close to you.
Thank you so much, Dr. Ganiyu, for that enlightening presentation. Indeed, the assessment is a very important one and a right step in the right direction. With health being in the concurrent list across the 3 tiers of government, and knowing that when there is a public health emergency or an outbreak, even though it may start in a state, but some of them do have propensity to spread and become a national emergency. So with the current structure that is in place, how do the national work with the state to address responses in a very timely manner, and also considering the outcome of this evaluation, knowing that some states, they are quite, especially those in tier 3 and 2, they are far from where they ought to be. So how do we ensure that when there's an outbreak or there's a public health emergency, there's a synergy that will ensure that it is timely nipped in the bud? Thank you.
Can I? Okay, thank you very much for the question. I'm happy that we have my colleague from NCDC. You know, under the Federal Ministry of Health, we have an agency, NCDC. And since NCD has been established, there'll be a lot of capacity building, a lot of resources. The state, that's why I use the word state-led implementation. The capacity of the state has been so built that they can actually respond to emergencies themselves under the oversight, most of the times with the support from the national. So I made mention of some of those outbreaks that even recently we just talked about the Lassa fever. That is currently Lassa fever. We just received a lot on that. I want to let you know that the state is capable at the moment with the support of NCDC, and we from the Federal Ministry, we all support. So the capacity of the state has been built. We are aware of that capacity, but we felt it's not enough. That was what informed the need for this assessment. We noticed that, like, yes, in terms of human resource and other, there are still some gaps. In order to further a kind of reposition them well, that is the need. That was what called for this assessment, so that they can be on their own to be able to respond. It's only when it becomes so necessary that we go in to support them. But in terms of support, the state capacity has been built to that level. Thank you. Yeah.
Okay, any other questions?
Yeah, good morning. My name is Elijah Idoko from Association for Reproductive and Family Health. Thank you for the presentation. My question goes specifically to the presenter from Edo that gave us a brief of what happened in Edo State. It's interesting to see the collaboration between the government and the partners driving health interventions within the state. So my question is, with the support of DataFi, a lot has been done, and it's basically said that they meet every Friday with funding from DataFi to review the data and analyze the data. So I want to say, what is the state doing beyond the support of DataFi, having seen the importance of this support, to see that the support is sustained beyond DataFi's project life? Thank you.
Okay, thank you very much. Before Edo should respond, I want to let you know that even at international level, whenever there is public health emergencies of international concern, you bring, so you get support from other countries. You remember during COVID-19, it was not only Nigeria. It's a normal process. What DataFi is doing, Edo, is to build their technical capacity. We've already, in the plan we are developing, there is plan for sustainability. I mentioned it earlier on. We want them to be alone. Because DataFi is supporting some aspect of data analysis, there may be maybe one of the gaps. And the purpose of doing that is for them to be able to stand alone in the future. So it's part of the sustainability plan. But in terms of response, I can assure you that Edo State, I'm not speaking for them. I'm speaking in line with the fact that we are all major stakeholders in the disease response in the country, that they can actually, when there is any outbreak, whatever. Currently, there is Lassa fever in Edo State. And I want to tell you that they are capable of doing that. The only thing is that we normally, at the national, my colleague is there, from NCDC, they can provide a kind of support. You know, support is, you cannot really, there is no feeding support. Whenever there are emergencies, you have to, pull resources, pull human resource, put materials from every angle just to make sure that you respond to that. So it's a collective bargain. It's not about standing kind of a thing. No matter, even Edo get to our level today, whenever there is emergency or whatever, they'll still need the support from other states, from the national and from partners. Thank you very much. Yeah.
Thank you so much, the National, for representing me adequately. Let me just ride on you. I don't want to repeat myself. He has said it all. There is a clear budget line in Edo State for public health emergency response. And His Excellency, we all know, we can take
go back to history during COVID. He's the only governor who was attending. I can confidently say that, who attend or who chair the evening review meeting of COVID on daily basis, morning, evening, twice a day, even at the heat of his election. So he was on ground. And he mobilized resources, financing, human, and all. Edo State is known for Lassa, like he said, and we are responding to Lassa. I think maybe, I don't know, I'm going to do a little presentation on that today, and you see the graph. And I will tell you how the government played their clear role in response to all these the outbreaks. Again, you will agree with me that even the federal, they need support from partners. Even U.S. needs support from partners. Partners help assist government, support government to drive the force in addressing any outbreaks. So DataFi have set out themselves to assist in this aspect. The state is the one that drives the force. But when we have any gap or when we identify any gap, they are always with us at our situation room, at our PHEOC meeting, and they volunteer to always support us when the need arises. And I can't do without recognizing them in assisting, in helping us to achieve what we have achieved today. Thank you.
Thank you. Do we have any questions? Okay.
Well, I'm Dr. Garba Anjuma, DG Taraba Saka. I want to join several others to congratulate Edo State for this beautiful approach to the response, especially the executive governor. Well, I know you are trying to bring everything under one roof, but I just want to find out about the issue of incident managers. I know in the past you used to see incident manager for COVID, incident manager for different disease programs. And by so doing, there is a lot of duplication and conflict sometimes even in the EOC. How are you able to manage, or how do you intend to manage the issue of incident managers for different disease programs? Thank you.
Thank you so much. We all know that at the event of any disease outbreak, the EOC is activated for that disease to handle the outbreak. And what the state does is it's always a prerequisite for you to appoint an incident manager. And we always, like what we have presently is Lassa fever, which is at the top jar, and we have to appoint an incident manager for Lassa fever. And that was appointed from the treatment center so that we can take a clue of our patient and know how we monitor them. But again, in that EOC, there is an office for incident manager. I know that outbreak, we hardly can have outbreak of many at a particular time. But even if it happens, there are offices, they can be activated at the same time, and they can work together. That was why I was saying that when I was making my comments, that we have a one health approach. One health approach in the same way we bring all stakeholders together in addressing, in focusing on what we want to achieve. So what happens normally is every year, if there's any outbreak like Lassa fever, which is our most endemic disease in our state, we activate the EOC for that purpose. And when the outbreak is down, then we can put it to an end. If there's any outbreak again, we activate. We have, when I go back now, the Honorary Commissioner is trying to activate a response for diphtheria. We've recorded 2 positive cases in diphtheria, and we're trying to activate the EOC. And in that response, we are going to appoint an incident manager. And that's how we have progressed with it. Thank you.
Dr. Lado, do you want to say anything? Please allow her to say something.
Okay, thank you for all the discussions going on around the EOC. So I will just add a little to it, starting from the response. When it comes to providing response to any public health event, is the sole responsibility of the state. And the states have been trained We've trained a couple of the RLT across all the states. The EOC has been well equipped, and also the EOC staff, they have the capacity, they will have the capacity building training to ensure that they know when to conduct a risk assessment and what informs activating an EOC for a particular disease. So when there is an event occurring, they usually conduct risk assessment to inform that decision. But when situation now occur that the states are not able to manage the outbreak, then they request for assistance. We don't even deploy. The states request for support in terms of medical countermeasures and response from the national. That is when we now respond by deploying team to support the state. But in terms of providing response, it's basically at the state level. And when it comes to activating the EOC, just like my colleague from Edo State mentioned, for each EOC activated, an incident manager is appointed. In a situation where you have enough capacity, you can appoint different IM for different outbreaks. But at the state level, they may not have that capacity. So at times, they may have an IM that cut across 2 or 3 diseases. And they are able to manage it effectively based on the magnitude of the outbreak. But for us at national, concurrently, we're running about 5 different EOC. Just this week, we activated EOC for heavy metal poisoning. There is a CSM EOC going on. We have diphtheria, we have Lassa fever, and a whole lot of that. And we have different IM managing this EOC, liaising with the state at different times. So just make sure that, although we have one ICC, but different times when these EOC meetings take place without any conflict of interest. Thank you.
Okay, thank you so much, everyone. Please, you can retire to your seat now, sir. Thank you for the questions. Please, a round of applause to him. You know, the beauty about this forum, it's been 2 days, but it's well attended, and we've had a lot of representatives from highly placed organizations grace the occasion and be part of the forum. While the presentations were ongoing, we had someone from DOD, Silas Idoko. Please, can you raise your hand so that we can see you? Please, a round of applause to welcome Silas Idoko from DOD. You're welcome. So if you think you've had a lot, wait till the next session starts. I can assure you that we have just started, and the next session is packed with a lot of presentations and discussions on other topics. And because we understand that fact, we want us to go and re-energize and refuel with the tea break. So we'll be breaking shortly for tea for 30 minutes, and then when we are back, we'll have other conversations and discussions on other topics that we have slated for you. Thank you so much, everyone. See you back in 30 minutes. So far at the forum, we can access them here. So you can just access the barcodes and see your pictures through that barcode. Thank you.
Hello. Welcome back from that short break. I'm sure we enjoyed our tea. So just to recognize a dignitary that joined us while the morning session was going on. Are we together, please? Are we together? All right. So just to recognize a dignitary that joined us while the morning session was going on, we had Mr. John Duru join us from the Federal Ministry of Women Affairs. Please put your hands together for him. You're very much welcome, Mr. Duru. We're happy to have you with us. We'll be going into a session that discusses data demand and data use for decision making. And we are going to have with us some representatives from some of the state ministries of health talking to us on some case presentations. But to coordinate this session, I am happy to invite to the stage a very seasoned expert, a seasoned management consultant and livelihood development professional with years of experience in health system strengthening, health financing, human resources for health, public health program design, institutional and individual capacity development. He's an economics graduate from Central University, Ghana, and a fellow with the West African Institute of Public Health. He has been able to provide strategic and technical direction across this range of health system pillars using a human-centered design approach, and has developed partnerships working with and collaborating with governments at the national and subnational levels, and international donors such as the BMGF, the EU, Gavi, Global Funds, the Medicine for Malaria Ventures, World Bank, and USAID. Currently, he's with Datafy Nigeria as the Strategic Information Lead for COVID-19, immunization, and other public health disease outbreaks. Now, please, if your hands are free, put a warm round of applause for Chukwuemeka Nebe as we welcome him to the stage.
Yes, good afternoon, everybody. I hope we are still energized and our morale is still high. So in the next 5 minutes, I'll be taking us through the situation room methodology, the situation room approach that we have applied to the COVID space and for other public health interventions. What is the overview? Also be discussing some of the results and impacts of the situation room approach in their individual states. So please, can I have the slide come up? Yes, thank you very much. So for the overview, we had USAID fund Datafy with the advent of COVID-19 in 2020 to support situation rooms across Nigeria, 8 situation rooms to be precise. We have in Adamawa, Akwa Ibom, Bauchi, Edo, Kano, Niger, and Oyo states. And the objective of this was to provide technical assistance to the state ministries of health. And across these 8 states that I just mentioned, we have technical assistance or SI advisors, SI associates, embedded within the situation rooms that provide insights, right, and help the state ministries of health in providing response to any public health emergencies that might be coming up. And then during this support, Datafy has strengthened surveillance systems with enhanced data analytics, GIS analysis, and data visualizations for informed decision makings by relevant stakeholders. During most of these meetings, we have stakeholders from a large sector of the ministries coming at the state level. While we were in Edo State on Wednesday, when the governor was giving his speech, he even made us know that he was a one-time incident manager during one of the situation rooms, right? And that shows the impact of what the situation room is doing across these different states. So we have Datafy through the SI advisors or through the SI lead, and then through sustainable capacity building of the SMOH officials at the situation room, provide this GIS analysis, right? It can be on COVID-19, it can be on public health surveillance, it can be on routine immunization, right? Just name it. They have it there and they're able to visualize this through different dashboards and other systems that we have employed. So this situation room approach, we have the method which we used to do it is we're prepared to have weekly meetings at the situation room. I remember when Dr. Stevenson was talking, he said that for their own situation room, they have these meetings every Friday. So it differs across states. And once in a week, they come, they sit down, they discuss the impact both for vaccination and surveillance on COVID-19, and then they discuss about other public health impacts or other public health interventions happening in the state as it is of priority to the state. We have some states that have outbreaks such as Lassa fever outbreak like Edo State. We have measles like as we have in Oyo State and Adamawa State. When they come up, hopefully they would share more on that and what the impact of this situation room has been in helping them provide adequate response to these public health emergencies. In total, for FY 2024, we have been able to conduct 134 meetings. Please, the previous slide. We have been able to conduct 133 meetings across our 8 states. So this is from October till April. We have been able to have 133 meetings across board to be able to strengthen most of the things happening at the situation room. And the major key stakeholders we have being part of these meetings are, we have the SMOH officials, as earlier stated. We have the NCDC, the EOC managers, or the IMEOC in this case. We also have in-country partners, particularly in all our states. We have WHO and UNICEF representatives in all those meetings because public health interventions are at core of what they do. We also have local NGOs and international NGOs also join. We have FHI in some states. We have Heartland Alliance in some states and the rest. So now moving to the next slide, I would like to highlight some of the achievements of some of our states using this situation room approach, right? As earlier mentioned, we'll have people from 4 states, that's Edo, Adamawa, Bauchi, and Oyo, come up to share their experiences. So I'll speak more on the other 4 states who are not physically here to talk about their own achievements. And I'll be starting with Akwa Ibom. So for Akwa Ibom, in October 2022, for COVID-19, there are 2 reporting systems, right? We have the EMID reporting system. We also have the call-in data reporting systems. For those who are familiar with public health intervention and how EMID work, there's always been a discrepancy between these 2 data sources, right? And DataFi working with the situation room has been able to some significant level to help close the gap between these 2 reporting systems. And then after that, the state has also taken it up with a state-led intervention to ensure that the sustainability of the gap between the COVID calling data and the EMID data are being closed. Currently now, the country is trying to move on from calling data into the into using EMID data. And then particularly for Cross River, we did something interesting in Cross River. It was one of our pilot states for our simulation interventions. So the simulation intervention, what we try to do there is we simulate that there's a disease outbreak, right? Most times these states are familiar with a national level approach to addressing public health concerns. So what we did in this case is, for Cross River, we simulated and we had a simulation exercise where we invited the LGA officials come on board, and then we let them know that, okay, assuming there is an outbreak of a disease in your LGA, how would you, as an LGA official, respond to this, right? So we did that simulation exercise. We had LGAs come up with their own LGA-specific approach on how to address public health interventions. We had them practice those approach in their states, in their LGAs, sorry. And for Cross River in particular, we had this simulation exercise happen in July. If you're familiar with the COVID-19 vaccination space, Cross River is one of the less performing states in Nigeria. And between July to September, we noticed a 20% increase of fully vaccinated persons in for COVID-19 in Cross River State. So this goes to speak about some of the outcomes of this simulation exercise and the simulation and the situation room approach that we have going on. And then for Niger State, so using the situation room approach in Niger State with the weekly review vaccination interventions, we were able to help through our visualizations and the action plans that come up with the visualizations. We're able to help the state SMOH get a 20% increase in their fully vaccination numbers between April and June 2023, just for Niger State. And then particularly for Kano, Kano is a peculiar state. So due to its peculiarities and the numbers of interventions of different partners happening in Kano, we have bi-weekly meetings in Kano. And from these bi-weekly data review meetings in Kano, we are able to help the state reduce positivity rates. There was a time there was an outbreak of diphtheria in the state, right, when it was really high. Through our interventions at the state, we are able to help them reduce the positivity rates. Testings we are still going on, but through active case testing and active case search, we're able to help them reduce positivity rates of this diphtheria outbreak, and then also help in increasing COVID-19 vaccination outcomes in the state. So to round up my slides, I'll just go to the next slide that gives us a concurrent chart, right, for some of our states, for 3 peculiar states, which is Akwa Ibom, Bauchi, and Edo State. How over time they have been able to bridge the gap between their EMID and call-in data. Don't worry, we are having a panel discussion now, so we'll go into more details of how they have been able to do it. And to lead the first presentation on the state's mechanism for situation room approach, I'll be inviting Mr. Titus Tenase. Mr. Titus is the PM CERIC, Program Manager for State Emergency Routine Immunization Coordination Center in Adamawa State. Please, a round of applause for Mr. Titus as he comes. Mr. Titus will be taking us through the progress made on scaling up COVID-19 vaccinations in 4 underperforming LGAs in Adamawa State. Mr. Titus, you're welcome, sir. Over to you.
Okay, good afternoon, everyone. I stand to give progress report on the performance uptake of COVID-19 in Adamawa State. As far back as April 2021 to September 2023. Now the context is showing us our target. Remember that for each state, WHO gave a target, each state should be able to cover 70% of their total population should at least be vaccinated. And for those who have been on this record will agree that Adamawa State was one of those states that was able to hit above that target. Now, our target population as at that time was 2,698,930. However, we were able to cover 2,627,938, making 97% at the state level. Ordinarily, one would say Adamawa has done well. However, there were 4 LGAs that could not reach the 70%, namely Ganye, Gombe, Madagali, and Michika LGAs, that the highest coverage was 65%. So this calls for concern because we have a target. And so if we are unable to get 70%, what could be responsible for these 4 LGAs that have pulled us down? And the next slide presents the performance of each of the LGAs, coverage of each of the LGAs. Now, if you look at it, you see that the lowest performing LGA was Gombe local government that performed only 44%. And then Madagali 63%, Ganye 60%, also Michika 60%. And so one of the things that we do at the Public Health Emergency EOC is to discuss issues like this, especially for this particular one. So this is just a graph that shows their performance, just like I have read. Now, the EOC, during their weekly meeting, start to know why these 4 LGAs could not perform, could not get to the target of the 70%. One was that the eligible target audience had a fear. We are taking a vaccine that we don't know. What will be the outcome? So they had that fear in them. Of course, there was also poor sensitization by our healthcare workers. Remember the AstraZeneca that that was issued to us has to be taken in 2 doses. So people came for first dose and were not informed on the need to come back for the second dose. So it was also an issue that was discovered. Of course, like we've all heard about the issue of data entry. You know that these 2 platforms, Daily Call In and then Emit, a lot of discrepancy. Our healthcare workers, remember that during that campaign, we engaged the Emit, particularly to do that, but there were a lot of discrepancy on the reporting for these LGS. And that gives the difference between the Daily Call In and then the Emit. There was hesitancy in one particular local government, which was Gombe. And that is why you could see that 44% coverage in Gombe local government. So they had their reason, cultural, and then EOC discussed that one. Of course, at the point, when people now started receiving, understanding that there was need to collect these vaccines, more people were coming. And the system of our vaccine is pull system, not push. So LGS has to come to the state cold chain to collect vaccines. So these 4 LGS were delaying, and before they could come at times, there was an out of stock of this vaccine. So these were some of the things that root causes of the low performing in these 4 LGS. Now in the situation room, as it is, look at it, during their discussion, so what else do we do? Now, first thing was that the risk activity for the COVID-19, now there was a need to sensitize people, especially targeting the Gombe local government that only covered 44%. How will we now mitigate this hesitancy, this cultural hesitancy? Of course, we also look at it, that there was a need to have a motorized campaign in our markets and schools, especially the high institutions that we have. In fact, one of those things we did was that we formed adult guards, friendly guards in those vanguards in those schools. So we visited them and they did a great help, which we'll now see in the reflection. Now, other health workers were reluctant. Some withhold the data because they were part of they were part of a ad hoc. They were engaged in part of the ad hoc assignment, and their little stipends were not paid. So some say, we are not paid. So they withhold that one, and then we said there was a need to do that. Then, of course, like I said from initial, that the health workers were not educating our caregivers on the need to come back for the second dose. So that was also discussed. And then we now look at how do we collaborate between the government and partners. So in the EOC in Adamawa State, all partners come together. No one is left behind, except for one that I will say later that we'll talk about on how they too will need them. Of course, it has been mentioned. So, but all partners meet there, identify problems, profile solutions, and then act in whichever aspect. So that aspect was strengthened. And also, we understand that the supportive supervision for routine immunization was weak. It was discussed, and partners along the government side agreed to strengthen routine immunization. Now, like we've said from initial, there was also a need, if it was a gap for these health workers that were not sending in their report from the daily call-in and also the EMIT, need for their reorientation on the need to operate well, as some of the EMIT were not really health workers, they were ad hoc staff that were engaged. And of course, training of healthcare workers on the cold chain system, which is very key. It's not just for them to come and pick vaccines at the state level and go, but then to also see how they manage the vaccines well so that potent vaccines are administered to our target audience. Now you can see the impact that came out as a result of the meetings at the situation room. if you look at this graph, it shows Gombe that was at 44% was able to achieve to 46%. And then Madagali that was at 60% moved to 63%. Of course, Ganye local government that was at 60% moved to 64%. And of course, Michika did greatly from 60 to 68%. Now, okay, these were some of the impact as these slides have shown. But I also want to mention this, that the EOC in Adamawa State was solely the handwork of DataFi. It has supported us, other LGS, to ensure that the discrepancy between the daily call-in and the emit has been bridged, because at the point, our data were being held at the LGS. So when the national court to say, oh, your daily call-in is this percent, why is your emit this? The data file TA that has been sent to the state this year, that he has to, at the point, say, okay, can we move to this LGS and see these emit persons who are holding our data, and how can we now support them? And they did that. And in a short while, before we realized, the national said, oh, we've seen your data, because they are sent. So on this short note, we want to say that we sincerely want to thank DataFi, coordinating all the partners, having a befitting, as we are talking today, our regular meetings host today, and we have an update. The laboratory pillar sent, and I saw the presentation. We have 5 cases of measles. We have from each of the LGS that came. DataFi also support us in our regular weekly meetings, maybe just like it is in other states, except for one thing that, like I've said, for the HIV pillar that has not been integrated, but I'm also comfortable because it has started in Edo State. Our executive governor is a very friendly governor. You know, his ATM governor, we call him. Amadou Umaru Fintiri, he's always on top of this. By the time we get back, I'm sure that if I present this to him, he will be challenged. And I'm sure that my honorable commissioner as well and the chairman of the agency will follow up this. Maybe the next state will be that, sir, you will be invited to Adamawa by His Excellency to come and also integrate. So on this note, I want to say thank you for listening, and I take my leave. I'm grateful.
Thank you very much, Titus, and it's very good and impactful to see the effect of the situation room in helping these 4 underperforming LGs reach their 70% target for fully vaccinated numbers, and to also see that Adamawa State is also willing to apply the IHEOC approach, the IHEOC structure. Dr. Ganiyu, I'm sure you're listening and you're taking notes of that. Hopefully, Adamawa will be the next state. And then for the HIV situation room integration, I'm sure our partners here and our funders, UACID, has taken note of that, and they would also help in making that a reality for you in Adamawa State. So going forward, I want to believe that we are all pleased and we are all receiving insights from most of the presentations that we are making. And going on to the next state, we're looking at Bauchi State. For Bauchi State, we'll be having Mr. Hussaini Alwal to come up, and he'll be presenting on improving COVID-19 immunization concurrence between EMID and calling data in Bauchi State. A round of applause for Mr. Awal, please. So, from most of the discussions, you have been hearing about COVID, EMID. I know when the World Bank person were talking about, we are speaking, they mentioned having an integrated health system approach that speaks to each other, right? So we have 2 particular data systems for COVID-19, and expected to speak to each other. Mr. Awa will give us an insight on how he has been able to do that in Bauchi State to make sure that these 2 systems speak to themselves. Mr. Awal, welcome, sir.
Thank you for the opportunity. Good afternoon, everyone. I stand to present the improving COVID-19 immunization data concurrence between EMID and the quality data in Bauchi State. So in January 2023, we meet with the COVID-19 technical working group where analysis was conducted to actually ascertain to see the level of concurrence between the call-in data and the emit data. As we know, the COVID-19 data is being reported in two platforms, which are call-in data and emit data. So the emit is real data, while the call-in data is paper-based that's being reported at the field, submitted to the LGA Yamani, while the LGA Yamani is summarized the team and submitted to state, then submitted, the state will be compile all the state data and submitted to national. However, we have been seeing actually there's a discrepancy between the two platforms. So what we did there, the situation room was actually sat down and analyzed what is happening on that data. So the analysis revealed that actually less than 50% of the LGA had, more than 50% of the LGA had actually less than 90% concurrence in the state. This is what prompted the state and the data file and the other partners in the state to come together and sit down to look at what are we going to do to curtail this kind of abnormal. So as discussed in the situation room, these are the leading cause of low concurrency between the emit and the call-in data, which the first one is a knowledge gap among the recorders. Actually, the refresher training is not being actually carried on regular basis to the emit recorders. And as at that time, there was a lot of upgrading of the emit, which is electronic management of immunization data, which lead to be having knowledge gap among the emit recorders. Then actually, we still notice there's reporting data on unavailable antigen. At that moment, at the state, we have only Johnson & Johnson, while some recorders are reporting Moderna, some are reporting Pfizer, some are reporting AstraZeneca, which is still an issue. So we notice still there is late reporting of data on the platform. So what has happened at that time is there was shortage of the QR code in some of the LGA. So they do vaccinate at that time, and they submit their call-in data report to the state. While the emit recorders, if they don't have the QR, I think they cannot do the registration. So that's another issue, we found it. Then still, we realized that there's a non-payment of stipend to emit recorders, which those that happen to do the COVID-19 activities can affirm that for the scale, either scale 2.0 or scale 3.0, actually the team works for about 90 days without actually having their stipend. Then also there is inadequate logistic for monitoring supervision of COVID-19 vaccination team. So at the state, both state and the LGA level, there was no any, there was inadequate logistic for the state and the LGA to move out to actually monitor what the team are doing in the field. So after identifying this root cause as discussed in the situation room, so we actually enhance the data review meeting methodology analysis by the COVID-19, which is served as a weekly situation room. We are sitting at the weekly to look at it, what is being reported on the call-in data, and we look at what is being reported on the emit. is the number of being reported on the calling data being synchronized to the electronic management of data. So we also triangulate this image and calling data. Then also, since we identified there's a knowledge gap among the recorders, so the capacity building to image recorders is being supported by the data file. Actually, data file have done a wonderful things here. In each of the LGA, they support about 25 image recorders. We have 20 LGA in the state, which make about 500 image recorders in the state. Were trained, capacity were built, which if you look at from the time we institute the review meeting, we have, our concurrency has been start appreciating. And to the time that we do the capacity building, you see we are moving from 33% to 38%. And going forward, we are moving since we don't have an issue of capacity across all our image recorders. Lastly, the WHO supported the state to supervise the entry of image backlog, which, as already explained at the back, the calling data is being transformed to the state, and state is being sent to national, while some image recorders were unable to record the client because due to the shortage of the QR code, due to the issue of network in some places. So this backlog data were supported by the WHO to actually upload this data, which in our end statement, if you can look at it, we set the end statement, and we are going to improve the concurrency between the calling data and the image COVID vaccination data from 30% to 85% by July 2023, which actually the end statement is achievable. As we can see, we are on actually particular target. So I think, thank you. This is what we have for Bauchi State. Thank you.
Thank you very much, sir. Please, you can sit down. Thank you. All right, thank you very much, Mr. Awal. So we'll be going into Edo State Emergency Operations Center situation room mechanism. And to have this presentation, we'll be having Dr. Stevenson from the Edo State Ministry of Health. He's the Director of Public Health in Edo State. This is also the first state to implement the IHEOC structure. Dr. Stevenson will be taking us through a data use case that speaks on reducing Lassa fever case positivity in Edo State and the roles of the situation room in getting this done. Please, a round of applause for Dr. Stevenson as he comes on board.
Thank you so much. Good afternoon once again. I'm happy to be in your midst again. Edo State Major Operations Center work endlessly to see how they can reduce Lassa fever in the state. We all know that Edo State is one of the states in Nigeria where we have Lassa fever endemicity. It's a viral hemorrhagic fever caused by multimammy rat. In January 2024, we discovered there was an outbreak again, which an increase in number. And the Emergency Operations Center, led by my humble self, in collaboration with the incident manager, which was appointed by the Honorable Commissioner, called for an emergency review meeting at the EOC, and an outbreak was declared on the 11th of January 2024 by the Honorable Commissioner for Health. At that point, we discovered that before the declaration, it was 23% of Lassa fever positivity rate. And data, we always hold our EOC meeting every Friday, which is being supported strongly by DataFi. And we're able to bring together those figures, and we work towards seeing how we can bring it down to the BRS minimum. Next slide, please. At Epic week 1 of that year, January, we stand at 20%, And with that tally, you can see that FPW2 recorded 23%. And that was where the Honorable Commissioner for Health declared the outbreak of Lassa fever. And our target was we're going to reduce the positivity rate of Lassa fever to 5% in March. Next slide, please. In order for us to achieve that, there was need for us to analyze the root cause. And what we discovered, as shown, it was a low awareness of Lassa fever in endemic communities, a lack of potable water supply in most affected areas, poor environmental sanitation in endemic communities, poor index of suture by clinicians who are seeing these patients in their various health facilities, and inadequate logistics arrangement for sample shipment. These were very key, and we have to now work to see how we can address those root causes. There were three areas we are looking at in addressing those root causes. We have state mitigation strategy, and stakeholder collaboration and capacity building. Those are the three key areas we believe we are going to use in approaching this strategy. The declaration of the outbreak was one of the stakeholder mitigation strategy. Then stakeholder engagement with the local government chairman and local government chairman to promote ownership of the outbreak was a very strong one, because we discovered that in order for us to harness and address it at this outbreak, we have to bring in the local government who are very, very key. Then clinician sensitization was also another one. We have to bring the clinician into a round table to discuss on the need for quick referral to treatment center. Then we realized that irrespective we are doing this, we have to also look at the root cause of this disease, which is the multimammary rat. We have to target the host by deratalization. This was done by pushing out rodenticides to address, eliminate some of those rats from our environment. Then we also conduct a Lassa fever outbreak investigation in the three hotspot local government, Eastern West, Eastern Northeast, and Eastern West local government area. Then the stakeholder collaboration involved a weekly data review meeting, which was also always supported by DataFire. This was to enable us to analyze the progression we are making in addressing the outbreak. Then the NCDC, WHO, ISTH, which is the treatment center, LGA Rapid Response Team, we always drag in to see how we can promote, health promotion activity, environmental sanitation, and infection prevention control in all those affected local government. And stakeholder collaboration with media houses and media houses to drive this message to the grassroots was also done. And in doing that, we have to select media houses across the three senatorial zones so that people will always get this message from the media. Then we also did provide engage a third-party logistician to help push mop the sample from the hospitals, clinics to the testing center, because we have only one testing center, which is Rat Specialty Hospital, and which is also the treatment center. And Lassa fever cannot be tested in all clinics. Even in UBTH, it was just with the effort of the Director Medical Lab and the State Ministry of Health, UBTH was just certified by NCDC now to now run Lassa fever testing. So the only center that was available in Edo State was Rat Specialty Hospital. So all samples were harnessed from the state down to that center. So in order for it to be effective, we have to make sure that a third-party logistics was put in place to always bring this sample. Because we discovered that mortality rate was increasing because of late presentation at the treatment center. And what was causing that late presentation was because the sample testing was not done on time, because the clinicians need to refer based on the result or outcome of the investigation carried out. So those were done at stakeholder collaboration. Then capacity building. We now know that for us to do well, we have to build the capacity of the people at the grassroots, which is local government health authority level. The DSNO, the health promotion officers, the community informers, the community mobilizers need to be trained. So then the local government rapid response team need to be trained. So all those training were carried out we train the health promotion officer, we train the local government rapid response team so that they can respond to any outbreak within the next 120 minutes in any of their vicinity. The community informant to go out there to sensitize the general public on the need to increase awareness creation, to be vigilant, and to report any sign of symptoms in any person they see around them. Then we train health workers in private and public clinics on infection prevention control. All this we are done to increase our index case of suspicion and the need to report quickly at the treatment center. Then we also increase supportive supervision from the state level, and all this we are all done together. We are monitoring our data at the situation room, which was always said by data file. Next slide, please. Now, the impact we got from this assessment is very obvious. The outbreak was declared Epi Week 2 at 23%. And after the outbreak, the government were able to release some funds for the state to achieve the rationalization exercise that is attacking the host so that we can see how we can use that to address the infection rate. That brought us to 9% when that exercise of rationalization was ongoing, but we were specific on the 3 high volume local government that were coming down with Lassa fever. So at Epi Week 6, we saw the percentage went to 21, and with the help of COPREP, supported by NCDC, we were able to mop up fund and spread around the 18 local government, digitalization, sensitization, and training, which was always, there for, and data file was always there for us to help us get data to follow our route, our analysis to see where we were. Fortunately, at Epi Week 14, we were able to bring it to 1%. And that is where we were saying, yes, we are home. Edo State, during the implementation process, we successfully reduced Lassa fever case positivity rate from 23% at Epi Week 2 to 1% at Epi Week 14. This implied that within the space of 12 weeks, we were able to reduce Lassa fever positivity rate in Edo State to 1%. This was the help of the state commitment in driving this push, NCDC support, which we are always there to send team to the state for outbreak investigation support exercise, NACA, and all other teams that we are going together, and data file, they were always there to help us analyze our data in our situation rooms. I must say that we are grateful to this, and our aim at this point is to sustain this and use the reports we got from our outbreak investigation response, which is still on, to see how we can sustain this exercise going forward. Thank you.
All right. Thank you very much, Dr. Stevenson. And it was a very insightful presentation. Now, going forward to the next data use case on how the mechanism for titration room work, we'll be talking about improving COVID-19 case finding in Oyo State. It will interest you to know that some states in Nigeria still have COVID-19, right? And it will interest you to also see how some of these states have been able to respond to some little outbreak of COVID-19 in their state. And the next state will be having the Oyo State Emergency Operations Center. We will have Dr. Iyabo Karim. Please, a round of applause for Dr. Iyabo Karim. Dr. Iyabo Karim is the state epidemiologist for the Oyo State Ministry of Health. She will take us through how they were able to improve COVID-19 case findings in their state and then also reduce the positivity rates incurred from those cases. Please, another round of applause for her.
Thank you, Mr. Emeka. So, good afternoon, everyone. Allow me to stand on the X16 protocol. So I'll be presenting improving COVID-19 case finding in Oyo State. By way of introduction, testing is important for early detection, prevention of spread, timely isolation of positive cases, contact tracing, clinical management to break chain of transmission and minimize morbidity and mortality. It also provides data for public health officials to monitor the trend of diseases and make informed decisions about public health measures. In Oyo State, a total of 173,771 people were tested for COVID-19 since the start of the pandemic, and which is roughly around 3.1% of the total population in Oyo State using 2006 census. This is relatively low. So during one of the COVID-19 review data supported by DataFi, these gaps in testing were identified and strategies were developed, discussed, and followed with implementation. Going by the next slides, which is talking about COVID-19 testing and positivity rates. While the testing continues in July 2022, at Epic Week 32 in 2023, testing continues, and it was discovered that the state had positive cases. This was what the state was responding to while monitoring our data, usually at our EOC meeting supported by DataFi. While we were responding, the state discovered that testing stopped, reduced even to zero level, which was of major concern to the state stakeholders. And at this point, we decided that we should include COVID-19 testing into public health activities. Using the graph, at week 50, we had Lassa fever intervention program in which we included COVID-19 testing, and that made us to get 89 people tested. Using the opportunity to integrate COVID-19 into World AIDS Day 2, we got 2,752 tested too at week 51. At week 52, the Oyo State had the opportunity to be included in enhanced COVID-19 testing projects supported by NACA, AFANET, NCDC. And this gave us opportunity to continue testing in Oyo State. I'll still talk more about enhanced COVID-19. Looking at the root causes of why we had reduced testing in Oyo State, we discover that people still believe there's nothing like COVID-19, despite what we have passed through in the state and in the world. There's still misconception about existence of COVID-19. There's still low risk perception about testing for COVID-19. They still have stigma and fear for testing. Looking at maybe they will get isolated if they test positive and other fears. We see one of the findings again is lack of support for community testing in Oyo State. Again, it was discovered that routine testing in our health facilities, COVID-19 is not integrated, is not included. So these are the actions that we went through. We plan using these strategies to increase COVID-19 testing in Oyo State. Looking at strengthening communication strategies, we engage and sensitize relevant stakeholders like religious leaders, market women on COVID-19 infection prevention, control, and testing. We still sensitize them about case definition so that if they are able to pick in the community, they will be able to report. We sensitize the health workers on differential diagnosis of respiratory symptoms. While doing our supportive supervision to LGAs, we discovered so many missed cases of suspected COVID-19. And this, we discovered that our health workers, though familiar with case definitions, but they didn't put it as routine testing. You agree with me that when you get to health facilities and there's fever, it's a must that you must be tested for malaria. But looking at what we have in our registers, we saw cases, fever, cough, without testing for COVID-19. We also sensitize the populace to address stigma and the fear issues. We integrate COVID-19 into routine diagnosis. The health workers were educated, sensitized again about testing for COVID-19 when we have respiratory symptoms to screen out COVID-19. It was also included in our plan. We integrated COVID-19 testing into public health activities like World AIDS Day, Malaria Day, HIV, and tuberculosis, and other medical outreaches. We also did supportive supervision to LGA facilities, to secondary health facilities, to detect COVID-19 missed cases and unreported cases. We monitor supportive supervision to testing centers, and we strengthen data reporting and surveillance system. Going by impact graph with aim statements to increase COVID-19 testing conducted in the state and maintain zero positivity for reported cases. Still leveraging on enhanced COVID-19 project testing, using outdated kits. Like I've said, Oyo State was choosing to be part of the states included in this project. This project, we selected 10 teams consisting of 2 testers, data recorder, and community mobilizers, in which they move around the 33 local governments we have in Oyo State, and they were testing 100 per day. Each team was testing 100 per day, making it 1,000 tests in a period for the state. So this one, we could see the effect. But at week 1, when we started monitoring our positivity rate, we saw that we had increase at week 6. That was at 1.3% positivity rate. This COVID-19 testing, the enhanced COVID-19 testing, we scale up the testing at our secondary and tertiary institutions across the 33 local governments in Oyo State. We got to the correctional centers, NYSC orientation camp, religious centers, and other places. And from here, we got increase in positivity rate, which got to a peak at week 6, getting 1.3%. And at this point, the state realized that we still have positive cases in the state. And we came in to intervene using this intervention. People were still sensitized that we still have COVID-19 around us, sensitized about case definitions to be able to pick these cases in the community for them to report. We educated them for them to avoid overcrowding. If they need to go, they must use their nose mask. Then for the positive cases, provision of free drugs were made to them, face masks, They were advised to self-isolate, and we're following up with them. We did contact tracing of these positive cases. And from this impact graph, we realized that with all these interventions, the positivity rates decreased, and at week 13, we had 0.0% positivity rate in the state. So from the presentation, the data file Pallidum has helped the state, has supported the state with weekly EOC COVID-19 data review meeting, which has given the state the opportunity to identify gaps in testing, to look at the strategies to increase testing, and with the help of enhanced COVID-19 projects supported by NCDC and other partners, we were able to realize that we still had positive cases in the state, interventions done, and we got reduced positivity rates. So thank you, DataFi, for the support. Thank you for listening. Thank you.
Please, another round of applause for Dr. Karim. Thank you very much, ma. And also, I would also want us to put our hands together for all the state persons who have presented their cases. We can see the impact that they are making. And it is also worthy to mention, right, this impact would not have been possible without the funding of our donors, USAID. Please, a great round of applause for USAID for providing the funds to do this impact in this state. And trust me, this is just like a tip of most of the impacts you see in the states. There are lots more impact that is being done across the states. So we'll be going into a question and answer session with the state presenters. So please, there's a paper on your table. You can scan the barcode and send in any questions you would like to ask the presenters who are here seated. Just look for the case presentation barcode, and then you can scan that and send in your questions there. So as we wait for that to happen, I have if you okay. Is anyone that has a question here, Fiska? Okay.
Thank you very much. I will start on the note of appreciation first to the back-end team of DataFi that is making all of this to happen. But just like someone asked earlier, I mean, these stories are very interesting, they are very impactful. However, my concern, like every other person in this room, would be that what happens today if DataFi is not in the room? Edo talked about, I mean, as exemplar as Edo case is in terms of the commitment first on the part of the state, which is key. And then we also see the intergovernmental, inter-stakeholder collaboration within the state entities, within the federal entities, and even the partners too, to make those things happen in the state. I mean, like Dr. Stevenson said, I was listening to him, he kept on mentioning NACA, NCDC, Daystar. It shows that they were not just doing their thing at their level alone. What happened if DataFi pulls out their SI support that you have in your state today to say, oh, Edo, you've had enough, we are taking him to another state? How do you intend to sustain that? That's for Edo. For Oyo, I was just having a side chat with my colleague that, you know, people have this idea about testing for COVID, even at the peak of COVID. The people were going for testing were those that had cause to travel. And part of the requirement was that COVID test result and all of that. I mean, we'll be very much interested in knowing what your state government is probably doing and will do, if those supports that came from NACA, NCDC, and all of that, if those supports are not there for you again, what will Oyo do as well? And lastly, I'll just add Bauchi and Adamawa together. You know, the commitment, like even in the previous panel conversations, the commitment of the government is very key, which is evident in some of the states that are making headways. We're looking forward to a situation where state like Adamawa will also say, oh, you know what? We've seen the good lessons from Edo. We also want to take up that challenge to do this. But in all of this conversation, if we pull out the donor support, what is the state bringing to the table? Thank you.
All right, thank you very much, Bayo. So I think what you're trying to find out is the sustainability approach in place across all the states. Yes, so to answer the question, maybe I'll start with Dr. Stevenson, the Edo State Director for Public Health. Dr. Stevenson, sir.
Thank you so much. I'm happy to dwell more on this. And I'm happy that you were in the state when we are inaugurating the PHEOC, the IPHEOC. And it's very rare in most of the states in the Federation for your governor and his entourage to be present in everything they do, most especially when it comes to health interventions. The governor of the state have built a system that is sustained because the first thing we put in our picture before embarking on any project is sustainability. The EOC you see today, before we embarked on building that EOC, what did ask ourselves the question, sustainability. And when you want to ask yourself that question, you have to ask, what are those things that will enable you maintain sustainability? For an EOC to function, or public health emergency response to function, you need power. Number one, in Edo State, our governor has been able to put that in place, even if it's not in government today. In that building you see, there is 24-hour power supply. It's not diesel, it's direct from Osimo Power Plant. Because we believe that with constant electricity, the EOC can function, data can be harnessed, real-time data can be fetched and be seen. Communication will be easy to accomplish, and every other thing has to follow. And that was why when the national was suggesting to the state that they want to establish the MBS Center, we said MBS cannot function without power. It needs to be situated where the state can own it. Because ownership by the state is key, and that is what we are after. And I must tell you that in the era of COVID, our governor did not wait for national. NCDC is here, NACA is here, many other partners that are supporting. They come and learn from the state. And they follow us through what we do. Aspect of sustainability, we are alive. We're open to support, but we can stand alone. The capacity of the state agents, when I mean the state agents, the workers have been built. We're still building because of persons who are living every day. We don't want to limit our capacity building. We spread them across board so that if one is exiting, another can occupy that position. If I'm not there today, there are many other persons that can take up my position and drive the process. And that is what Edo State have established. So even if the national are not there, I believe we can stand alone. We are not depending on data file. We are not depending on USAID. But we welcome to their support, and we can drive the process. Thank you.
Thank you very much, Dr. Stevenson. And it's very good to see that the Edo State Governor, Mr. Godwin, is very active with public health response. And this was evident yesterday during the inauguration of the IHEOC approach on Tuesday in this state. So just to round up, I'll hand over the mic to Dr. Karim to speak on any sustainability approaches in place in Oyo State to make sure that the situation room keeps working if there is no support from DataFi or from any other partners supporting.
Okay, thank you. When this enhanced COVID-19 project was about to start in the state, one of the requirements from NCDC and other partners was a sustainability plan, the Oyo State, how we are going to continue. And I remember we gave them, just to tell you that we have our plans to sustain this testing. In fact, the Honorable Commissioner for Health in Oyo State was so desired that this testing must continue because of positivity rates we were able to get with the support. And the plan, apart from what we are planning, she decided that there's going to be budget line for sustainability of this testing. The plan was to continue immediately because the program has ended in April. But unfortunately, due to the situation in the country that the RDT kids, I don't know the plan to get new ones. So if we had one, if we still have RDT testing kits, would have commenced immediately to continue testing using going to settlements that we realize that they have low testing, using the medical outreaches I've mentioned before, leveraging on public health activities, which we've planned that we'll continue with. Thank you.
Thank you very much, Dr. Karim. Please round up of applause for her. So I understand, we know that sustainability is a key issue and a key discussion, but we are aware that we have other questions being sent in using the barcode code. So just to round up the sustainability part, I would let the PM CERIC for Adamawa State, Mr. Titus, put some comments on how Adamawa State, what approaches are in place for sustainability in case partners begin to pull out, in case funding comes to an end.
Thank you very much. To start with, for Adamawa being in category 2 for your assessment shows ownership by the government of Adamawa State. Now, DataFi USAID supported by establishing the EOC. But it is cited within this. I think for the past 1 month now, we have issue of light in Adamawa State, but our EOC has a solar that is being supplied there. Besides, our state government has engaged stakeholders when we had that pandemic. If you go to Yola today and stop a Keke Napep man and ask him, take me to Corona Hospital, they will take you to Corona Hospital. And the hospital was donated personally, by meaning that stakeholders in Adamawa State have ownership. If our partners, which I believe that all partners cannot pull out at the same time. This one will pull out today, next another one will still be there. And one other thing that we have benefited is the fact that the state government health workers have been mentored in such a way that EOC will continue to function. Like I've said in my presentation, today is our EOC day. Our DataFi PA is here. Myself, I'm here. But it went on, meaning that there will be no vacuum. So Adamawa has put in place strategy to ensure that once they pull out, because of the experience we had during the NSHIP. Remember, Adamawa State was also one of the states where we had the NSHIP project. So, and one of those things that NSHIP did was the sustainability plan for every health facility. I'll assure that those facilities that were beneficiary of the NSHIP during the PBF, today they had their sustainability plan and they're being sustained. So if the state could implement that at the facility level, I assure you that at the state level, EOC will not. No wonder I am opening my chest to tell you, maybe next, if we are live, Oga will say, okay, he's in your life. He will hear a call from either the chairman of the agency or the honorable commissioner say, okay, what are the modalities? Because I know that our governor is the one that can pick challenges. And in his 10-point agenda, health is key to his own agenda. So I assure that, however, like I say, summarily, we sincerely thank Data Fi, USAID for establishing our EOC. It is there. So we have a plan. Thank you.
Thank you very much, Mr. Titus. Please, a round of applause for Mr. Titus, please. Please. Thank you so much, Mr. Titus. So it's good to see that not just Edo State, but also in Adamawa, we have the governor, His Excellency, also having public health as a key part of his intervention. Just as the Titus was saying, as an add-on to what he was saying, as us as Data Fi as a partner, what we are doing for sustainability is you can see that he is actually here and he mans those EOC meetings. The SI also in Adamawa is also here. But these meetings are still happening. These analyses are still going on, right? The state has been onboarded with the capacity that they actually need to make sure that these meetings keep running. Whether Data Fi is there, whether the partners are not there or not, they are being equipped with skills on data visualization, analysis, GIS, and the rest, data use, right, for decision making. They have been equipped with these skills, right? It is now left for them to make sure that even if the partners are not there, or with the little skills that they have, they're able to put that into action, and also with the commitment of most of the executive governors on their end, they're able to make sure that this sustainability approach are in place and keep running. So I was informed that we have some questions coming in from the barcode scan. Dr. Abba will take us through most of those questions, and then we'll have the presenters present. But Dr. Abba, please, before you go, Dr. Ladun has her hands up. If you can please allow her ask her question, please. Thank you.
Thank you very much, and thanks for all the presentation. So I have a few questions, then I'll touch on the enhanced surveillance project. My question, first of all, to Adamawa, thanks for that beautiful presentation. And I'm just curious, what are the examples of cultural hesitancy that you witnessed at the state level? You know, we're very familiar with the vaccine hesitancy generally, but you termed yours a cultural thing. So it would be good to share more light on what are those cultural hesitancy. And aside that, very wonderful work you're doing on COVID-19 vaccination, but beyond that, it will be good to look at the lessons learned from that process to also translate to other routine immunization so that we can use the same method to strengthen the routine immunization at the state level. To my colleagues from Edo State and Oyo State, thanks for the presentation on Lassa fever and COVID-19 testing. Looking at the root cause analysis, you're aware when it comes to incident or any public health event, we also have a 717 approach that we use to determine what are the bottlenecks, the enablers. So it will be good to see how to marry this together so that we'll be able to have an holistic response approach moving forward. And to add to the enhanced surveillance project, so the idea of the enhanced surveillance is actually to start the process of routinizing the COVID-19 testing in such a way that at the end of the day, we'll be able to incorporate COVID-19 into our priority diseases. That's how the project started. And we're hoping to continue. Every state started with the sustainability plan. They have their sustainability plan in place, and the plan was for NCDC, NACA, and Global Front to support for a period of time, and the state would take over so that at the end of the day, we'll have our routine COVID-19 data. But unfortunately, the kits along the line got expired, and we're in the process of getting more supply. But as we've been saying, health is under concurrent list. So as part of the sustainability plan, every state procure their own RDT kits moving forward as part of their own public health response strategy. Thank you.
Thank you very much, Dr. Lado. So, PM Serik, sir, I'll let you pick
Thank
the
you
first
very
question.
much. Remember, I said specifically Gombe local government, where the coverage was only 44%. Hesitancy was the fact that the elderly people in the community refused receiving because they say of their age, they do not need any of these vaccines to be administered to them. Because why is it? He said, what else do we need? So, and we were asking, and there was no reason. They said, no, we can't do that. It will also interest you to know that engagements later convinced them, and they came to differentiate between the different companies of the COVID-19 vaccines that were administered. Unknown to us, they now came and told us when we got the Pfizer and we administered to the elderly one, there was the one that were coming and were asking, you must give us Pfizer because they know. And we asked them why. They said Pfizer was taking care of their arthritis, was taking care of their BP. That was what they said. They said high blood pressure was coming down. So they were the ones that were moving around and were saying, okay, give us, but specifically Pfizer. So the engagement helped. They that refused initially as cultural, later on accepted. But then the only challenge we had was that they were specific. They will come and tell you we need Pfizer. And we don't know how they came to know about it. We don't know, there's no scientific proof. But for us, since they were willing and they came to accept, even the J&J was not even an issue to them. To them, they will come and say this. Some of those best practices, like you said, should be done in that was applied, was that one, the affiliates were supporting Adamawa State then. Now they engage some teams and they gave them daily target of vaccinating 70 per day. And they were paying bi-weekly. So that gave us an advantage that even the state teams borrow to say, okay, can we set target for our teams? Also, since 70 has worked out for the Afone CDC, and we did that one. And that has also helped in all other edges that they're able to, the uptake has gone up that. So these were some of the things. Like I also said that the engagement with the religious and traditional leaders also play a very vital role. Once they inform their followership, they are convinced. So those are some of the practices that supported us to get to where we got to. Thank you.
Thank you very much, Mr. Titus. So for the next question on how the state was able to respond to Lassa fever using the 717 approach, right? I will hand over to Edo to take that. Dr. Stevenson, sir.
Yeah, thank you so much. Well, no, that is always put in place. Yeah, we cannot be exhausted in this meeting. In 717 approach, deal with, first of all, case investigation, root analysis course, then before you now come up with your, process. So that was always considered in the whole process. It was always considered. So that's it.
All right. Thank you, Dr. Stevenson. Then finally, I know Dr. Ladon mentioned enhanced surveillance. She talked about enhanced surveillance. And we have Oyo State practice some bit of enhanced surveillance when they mixed, she mentioned mixed COVID-19 testing with other routine testings at the health facility. Dr. Karim, please, do you mind to provide some insights on enhanced surveillance that happened in Oyo State before we go to other questions?
Thank you again. Part of enhanced surveillance using COVID-19 is to get to health facilities. I mentioned it as part of it. That our health workers, it was realized that they were not, COVID-19 testing is not part of routine testing in health facilities. I gave the examples of fever, using our malaria rapid testing. But we discovered that a lot of fever cases with cough, which is going to the part of case definition for COVID-19, And despite this, our health workers were not using the opportunity to screen out COVID-19. So part of it is to sensitize our health workers on case definition of COVID-19 again, and integration of COVID-19 testing as part of routine testing in our health facilities. This is very, very important. When we see symptoms, respiratory symptoms, it should be at the back. Our health workers should have it in their minds that this could be COVID-19, and integration of COVID-19 testing should be integrated into routine testing in our health facilities. This will help us in surveillance for COVID-19 in this state.
Thank you very much, Dr. Karim. So I'll hand over to Dr. Abba to give us one of the questions, and then we'll wrap up the session. Dr. Abba.
Okay, yeah. So I think you've answered some of the questions that were directed to you. But one last one here says, were there any specific activities implemented in your state to reduce the positivity rates?
So positivity rate for Lassa or for COVID?
I am guessing it's COVID. Yeah?
Okay. So Dr. Karim.
Okay. I think I mentioned it, that when we got the high positivity rates, while having enhanced COVID-19 testing projects, we used the opportunity to sensitize our health workers on case identification for COVID-19. We did intervention for positive cases because we believe that if the positive cases were isolated, were well managed, it will reduce contacts, and this will reduce the positivity rates in the state. So we use, we did the management, case management, though the positive cases were actually mild cases. They were not severe cases that required admissions. So most of them were advised to self-isolate while we did follow up with them, to use nose masks, to avoid contact with other family members, to stay at home. And we did follow up, like I've said, with them. There was also provision of free drugs for those positive mild cases.
Okay, thank you very much. To wrap up the session once again, I would like to specially thank USAID, who has made the funds available for us to be able to have these impacts in the state. Please, a round of applause for all the presenters as they leave the stage. Thank you very much.
Please, another round of applause for the panelists. We have just been educated on some of the great results coming from DataFi across some of the partner states and some sustainability mechanisms they have in place to make sure these results are sustained with or without donors. And I think these are very fantastic stories coming from the amazing work that DataFi has been doing. So please put your hands together and appreciate DataFi and USAID for achieving all of this. So we'll be going to the next session, which is community-level interventions through digital solutions. We are going to be having a presentation on showcasing digital applications supporting community-driven interventions, a case presentation on national OVC management information system, that's the NOMI system. And this will be taken by someone that is a biochemistry graduate, passionate about public health, and has leveraged his expertise to spearhead impactful interventions in Nigeria. With a master's degree in biochemistry and relevant certifications in public health, data analysis, and database management, his journey as a strategic information advisor with DataFi has been marked by innovation and dedication. He's a key player in orphans and vulnerable children initiatives and has pioneered transformative projects, including supporting the development and deployment of the National OVC Management Information System, NOMIS. He presently leads data-driven strategies and leverages his expertise in data analysis to drive impactful public health interventions. He's experienced in USAID, FCDO, and CDC-funded projects and has gained valuable experience working on different projects across different international and national non-governmental organizations. Beyond his professional endeavors, he has love for family, and his passion for children's intervention drives his commitment to making a difference. So please put your hands together and welcome to the stage Seyi Abolarin to give us his presentation on a case management on the National OVC Management Information System. Please keep clapping while he makes his way to the stage.
Yeah, good afternoon, everyone, and thank you so much. Permit me to stand on the existing protocols. All right, I think I have just a few minutes to do this. Sorry, who is the slide? All right, thank you. So in the next few minutes, I'm going to walk us through some of the great endeavors that DataFi has been able to play with respect to the National Orphans and Vulnerable Children Management Information System. It's an application that has helped, or that's helping to help track information around vulnerable children in the country. And this has come this far through the support of USAID as well as the Federal Ministry of Women Affairs. And so, to give an overview of what NOMIS is generally, it's a national case management information system that is used to, track, monitor, and also streamline every report around orphans and vulnerable children in the country. This system was designed to be scalable, to be flexible, and to also have the ability to interoperate with every other system across the country that has to do with any information around orphans and vulnerable children. And of course, the system, we know, we must have been hearing about NOMIS probably before now. It's a system that was collectively or collaboratively implemented, developed by every major stakeholders in the country, that has been spearheaded and led by the Federal Ministry of Women Affairs, grassroots NGO organizations in the country, as well as, of course, the different agencies, which includes both the USAID, the CDC, the DOD, and even non-PEPFAR organizations who had come together to see how we can have that single unified system in the country that allows for us to be able to track and manage and monitor everything around orphans and vulnerable children in the country. All right, so the system, we have some key features that we have been able to build into the system. Part of the things the system does is that it helps us to be able to manage the various interventions we provide at the household level. Of course, we know that the orphans and vulnerable children intervention is targeted to community intervention, focus driven. And so it allows us to be able to monitor, track all these interventions across the household level of the caregivers, the vulnerable children themselves. And so it also helps you to be able to have a flow, to see the flow, to see the level of services you've provided to the members of those households. And so the membership is also part of the feature you get to see on the application. It also allows you to be able to design a tailored care plan. Now, the care plan, it's more like your performance scorecard that allows you to know the specific kind of intervention you have itemized alongside with the caregivers of this household that you want to provide for them within the space or period of time, just to be sure that at the end of the day, you're able to achieve the goal that these children or this particular family had successfully come out from every situation that have tagged them to make them to be vulnerable within the society or within the country. The system also helps us to be able to manage the service provision that you can do. It's designed in such a way that you are able to not just know the service provision, you can give a service provision tailored to the vulnerable child himself or even to their caregiver, and you can also determine, a particular household that is yet to receive any of those services and to see how you can, work swiftly to make sure that they get those services. At the end of the day, the simple goal of those interventions is to be able to get the household or the people to a state where you know that they are stable when it comes to their economic stability, their educational stability, emotional stability. When they get to that stage, you also have the opportunity to review what you have done for them. So the system allows you to do that. In OVC 10, we call that the Care Plan Achievement Checklist. Once they meet all of those checklists, the system allows you to systematically graduate them from the program. So it's part of the feature you get to see. Also, other features are quite embedded within the system, the print features and several other fantastic features that had gone into it through the effort that was led by the ministry data file, of course, through the funding from the Federal Ministry, through the funding from USAID and every other partner who have been key players in the application. Some other additional features you will get to see has been displayed. It's the ability to generate real-time reports from the system and also the ability for the system to integrate with other systems. To take, for instance, LAMIS Plus presentation was done yesterday. We've been able to integrate the NOMIS with that LAMIS Plus system, and it can also integrate with other EMRs in the country. It also has other features as well. Now, the system is built in line with the case management flow of the OVC program, which stands from identification of the vulnerable children, the ability to enroll the children into the program, and then to conduct some level of assessment to know their degree of vulnerability, and also to be able to update and develop a care plan, as well as to monitor the implementation of that care plan to be certain that to a degree of an extent after your intervention to that household, they've been able to achieve stability, and then you graduate them from the program. Also, you will get to see that part of the things that were built into the system are the case management modules that allows you to be able to, add a new case manager. You can deassign, assign, reassign case managers, because we know in this sector as well that sometimes the case managers you have built their capacity might get something else and they would move. And so the system allows you such that you don't become stranded at the end of the day. You have that unique ability to manage all of those case managers. These are the features that are also built into the system. And also, of course, there are other things that the system does, which is NOMIS itself. It allows you to also have the ability to do a lot of things. And part of the things we were able to do in the course of getting what we now call NOMIS 3.0, which was being led by Datafy, working with every other of the organization, it's that probably before now there was an extensive system requirement gathering where all stakeholders across the different sectors were brought together to tell us about the systems they are using, what they would like to see implemented into NOMIS 3.0. All of these happened, stakeholder engagement took place, and then the design of the system came into being. And of course, series of trainings were then conducted and all. So far, so good. What has been the impact of the application? Across the entire USAID state, this application has been successfully deployed, of course, with continuous technical support ongoing to ensure that they're able to have full grasp of the entire use of the system. Other things that have been done also across the DoD part as well, the agency, they are also using the system to monitor and track the interventions of orphans and vulnerable children. Same with the CDC, who have just recently commenced with the deployment of the system. And one unique thing as a result of sustainability is also the fact that we now begin to have actors of non-PEPFAR who are also interested in deploying the system within their program. So take, for instance, we have other NGOs who are non-PEPFAR, who had also shown interest, and have reached out to Datafy to see, of course, to the ministry as well, to see how they can also onboard the application of NOMIS. And just to also add is the fact that the application is a web-based application. However, to help with the full maximization of resource allocations, to reduce the burden of paper usage and all, part of the other initiatives that was done was to come up with a mobile version of the application, such that with the help of the mobile version, you're able to go into the community, provide your intervention easily, and then sync your information to the web. The individuals at the office get to see what they've done. That way, we save the cost around the resources that we'll have to use to print OVC tools, paper tools, and all. That phase completely goes off. Another thing is the fact that you now get to have what we call real-time information, and the architecture around the mobile application is built in such a way that it can pull data, it can also push data, it can sync the data to the web, and at the end of the day, you get to see whatever is happening real time within the facility or within the community. That's the architecture around the push, the pull, the sync that is being displayed on the screen. I think I will just go straight quickly to also the aspect around the security that has been put in place on the system. So quite a number of security has been put to ensure that client-level information are well protected, they are well conserved, and they are well safeguarded. And so one of the things is we've been able to implement on the application data encryption at rest and in transcript. We've also been able to push access control to only authorized users. Take, for instance, the mobile version of the system. If you allow it to stay for a few seconds, it goes off. You will not be able to have access into the platform except you are the real user or the real owner of that application. We've also been able to ensure that there are continuous security updates on the system, as well as, of course, and also developed other security SOP manuals that can guide and help the users of this system in making sure that they use it very well. Also to add is the fact that we've been able to also put in place some unique thing that will help the continuous use of the system, and also help to make the community or the users of this system to be kept abreast with all the functionalities within the system. So one of the things that has been put in place is a real-time live help desk, where as you're making use of the system, if you have issues, you're able to quickly log your concerns into the help desk, and you have individuals who have been dedicated to mount that help desk that provide immediate response to you in record time. And then if it's a situation they're able to solve, they solve it right there and there. Otherwise, they escalate those information, and then quickly the developers behind the scene get into action and see how to provide that support. We've also put in place series of trainings that have been conducted before now, but of more recent things around webinars that we're coming to, and you'll be getting those invitations to participate in some of those webinars, where you get further exposure around the use of this application, what the application is used for, and how to easily navigate your way through this application. Of course, part of the things to also ensure full sustainability, which is of course government ownership, is through routine monitoring visit, whereby the Ministry of Human Affairs and every other individuals will be partaker of this visit, just to ensure that this application are being used efficiently and effectively to track and do anything around data management as it relates to orphans and vulnerable children. I mean, quite a number of things are ongoing for this. Like I said earlier on, in terms of the achievement, we've had a wide-scale adoption of this application across all the interagencies and, of course, of recent non-PEPFAR implementing partners. Of course, there are lots of improved and enhanced features that have gone into this. Now you can generate quite a number of things in terms of report, in terms of register and some fantastic features like the print features that you can easily print at a glance, see what you want to see, and you are good. And of course, interoperability with every other system. What is the future of this application? One is to see how we can further also integrate it with every other systems, that are still available out there, just to make sure that as a country, as a whole, with the goal and mandate of the Federal Ministry of Women Affairs, to have a single unified system that they can use to capture and report information on orphans and vulnerable children in the country. That's the goal we are going towards right now, to see how, if there are other existing systems outside still capturing information of orphan and vulnerable children, we're able to bring them together, absorb them into normies, and then we have a single system for the entire country. Also is to make it a full global standard. Of course, all of the things that have gone into it in terms of the development are things that, ensures towards global good. And so we're trying to also see how best the application can even go beyond the shores of Nigeria and become an application that every other country will be interested in and also buy into. Of course, user improved experience has been done to make it more user-friendly for everyone. And of course, the analytics part of it has also been embedded to make it such that when you need to generate information, you're able to generate information in record time. And so these are the various things that have gone into NOMIS application, but all of these were not without the full support of all the various implementing partners across the different agencies. Of course, also not to forget the fact and the great role that the Federal Ministry of Women Affairs had played, from the director to the minister to every one of them. And of course, lastly, to our funder, which is USAID, who has also given us the full support behind all this, pushing us, supporting the mission, providing the resources, and of course, lastly, to all our management in DataFi as well, who has ensured that, working behind the scene to make sure that this application is tested day in, day out to attain that global standard that it ought to be. I mean, this is the presentation for today. I think at this point, I will call on Dr. Abba to come and moderate the panel section, where you will have the opportunity to listen to some of some of the major players who have been in the forefront in driving this application, and then you get to ask them questions, and hopefully, I'm sure they will do well to be able to respond to some of those questions to you. Thank you.
Thank you so much for giving us that wonderful presentation on the NOMIS platform. Just to keep the ball going without wasting much time, I'd like to invite to the stage the moderator for the next session. It's going to be a panel session, and it will be moderated by a seasoned public health professional with over 5 years of experience implementing HIV, AIDS, TB, reproductive and maternal health, COVID-19 and prevention programs in resource-constrained settings. Throughout his career, he has demonstrated exceptional technical leadership and oversight skills by leveraging data analysis and interpretation to drive program implementation processes. Please put your warm hands together for Ikechukwu Abba, Dr. Ikechukwu Abba, as he comes up the stage to moderate the session. Please, a round of applause for him. Oh, we can make this better. Can we please clap for him? Thank you very much.
Okay, thank you so much, Abigail, for that wonderful introduction. We've been seeing a lot of my face, so I don't need so much introduction here. But we have so much to discuss around OVC, and of course, we'd want to hear from the panelists, those who are implementing, those who are coordinating, and we have seasoned professionals who are here to do justice to the topic. So I would quickly introduce them to the stage so that we can commence the conversation. So the first person we have on our list is from USAID, and he's a seasoned project management and strategic information specialist. His name is Dr. Olubenga Saulu. Please, with a round of applause, can we invite him to the stage? The next on the list is someone also from a coordinating agency, DOD specifically, and he's in the person of Silas Idoko. Please, with a round of applause, let's invite him to the stage. So again, it won't be a complete panel if we don't have somebody from the government. So again, we have somebody in the person of John Duru, who is from the Federal Ministry of Women Affairs. Please, with a round of applause, let's welcome him to the stage. Again, to contextualize the conversation, we have somebody from an IP, and that's in the person of Innocent Pius Banki. Please, with a round of applause. Also, someone who provides technical assistance to one of the partners implementing the OVC project, and the person of Victor Namdiago. Please, with a round of applause also, let's invite him to the stage. And the last person on the panel, who we just listened to eloquently talk about the systems you've been used, I'll invite back Sheyi Abonlarin to the stage. So when we discuss OVC nationally, one major thing comes up, and that's NOMIS, the major system being used for implementation of OVC. And there has been so much investment in this area. And so what we hope to achieve with this panel session is to delve into challenges, discuss about the experience, and we feel that there are some lessons that could be learned for other community-based interventions in the use of the NOMIS for the OVCs. It could also be contextualized to other programs implementing the community-based program. So we're hoping to also delve into that. And lastly, talk about future improvements which we feel are required for the system. So to start off, I would like to start with Innocent. How has this NOMIS, because we've been hearing NOMIS, how has this NOMIS helped with the community outreach interventions across the OVC implementation in your own area of practice?
Right. Thank you so much, Dr. Harper. Let me start. We can't talk about NOMIS without actually appreciating those that have made it possible, in bringing a better kind of platform for us, to report and have a quality kind of information system. I'm saying this because, when you look at 15 years down, the line, we that belongs to that generation of, reporting before the development of, the NOMIS, you will appreciate so much, the investment that has been done to bring up this excellent and formidable platform that we are currently doing. Let me thank especially the government of Nigeria that has created that platform, the USAID, the heavy investment they've done also, with other stakeholders like the CDC, and paramountly, the data file, what they're currently doing, and to give us a kind of a better, reporting platform. She has said so much, about the functionality, what we're currently getting from the NOMIS, but I can tell you, with our practice currently ongoing, NOMIS give us handy, data that we're using easily for decision making, resource allocation, and what have you. This thing is not possible before. I know before now, when you want to plan, you have to go back to registers, paper-based tools that, before you just get ordinary data on a particular indicator, you have to take, sometimes days, because you have to go back to all this enrollment register, service register, to start counting manually, to produce summaries, before you can report. But I can assure you, with the current NOMIS we're having today, it's just a bottom. I remember just of recent, we ran analysis on our data and we discover, that we underperform on, OVC education. You understand? And that's in Kano particularly. And immediately, we just went into deep dive and know exactly per school, where is this thing coming from? And we generated the data, share it with the team, our CQI team, also we shared. Before the last quarter we improved tremendously. You can't do that in the previous implementation. So we are seeing a lot of, development, ease of our reporting, data management is different now. You have an improved data management, data collections, running your analysis, sending your report. You have a beautiful dashboard, for you to, in a twinkling of an eye, you've put up your presentation, you share it with, your team, your managers. Before you have a quick, implementation, and you attend to issues easily with the current norms. So a lot currently we are doing to improve our implementation, using this platform. Thank you.
Thank you so much. So it's safe to say implementation has come a long way. There have been changes, there have been transitions, and we can only get better, if I would say. I will come to you, Victor. In your experience, and so far with your interaction with the system and implementation, how do you think digital solutions like Nomis, for example, can enhance planning and delivery of targeted interventions for the vulnerable children?
Okay, thank you. A lot of response to this question also been highlighted by Sheyi when he was presenting. Basically, we noticed from the presentation that Nomis allows for client-level intervention, following the case management model, where you enroll individuals and you're able to develop a care plan that addresses the specific needs of individual beneficiary. Now, with the use of Nomis, you're able to track those needs and how you're providing intervention to meet the household and household member needs. Now, the Nomis for CCW, that's community case workers, using the mobile application of Nomis, can easily follow up on what service a household member requires at any time. And on a click, we're able to know if this person has received this service that is due to receive, and be able to plan on how to provide the service in due time. So Nomis has really helped improve the efficiency in terms of managing clients, targeted intervention for individuals. Unlike in the past where services are mainly like generalized, you provide intervention without really considering if this is limiting the needs of particular individual. So Nomis will help you to, following that case management model and the care plan design, you know what a child or the caregiver needs at a point in time, and be able to track when this service will be provided and also provide it. So it helps provide that targeted intervention for individuals and the beneficiaries in that household.
Yeah, that's amazing and that's interesting to get that from your own perspective. But Silas, I would come to you now because I want to know what your perspective is from the coordinating agency, for example. How do you think this has helped improve planning and targeted interventions?
Particularly for DOD, we started the intervention in 2022, precisely February. And after the training, DataFi came to train us on the use of the Nomis. And we work with the military particularly, and data security is a serious issue with them. We were told that their data cannot be domiciled with any individual at the facility level or probably with their systems. So one of the help that we've gotten was to call on DataFi that is it possible for us to host the Nomis particularly on the web, and it was made possible. Currently, they do the entry on a real-life basis, and we pull the data in our office, and that has not been achieved in any of the agencies except for DOD particularly. It's a big achievement on their side, and also particularly, of recent, we wanted to provide household economic strengthening for
an individual household based on their vulnerability level. So the initial time when we did this, we piloted 50, and it was handpicked and selected from the community volunteers themselves based on whom or what they failed to do. But we equally have to liaise back again to DataFi, and there was a check that was put in place at the office level based on the initial need assessment that were done. If it is properly done, all you need to do is to provide, pull the data, and you should be able to have a tailored intervention based on each individual vulnerability level. So there are lots of enhancements that have been done, having used it from the community-based organization level down to IP level, and I'm currently also implementing from the donor level. So far, so good. There are lots of enhancements, and issues of tailored intervention have majorly been improved on it.
Thank you so much, Silas. So, Mr. John, I'll come to you now, because this is a lovely system, and it's having so many advantages and helping in different areas of implementation, especially for the vulnerable children. So, thinking sustainability, thinking scalability, what has the government done to ensure that this system, which has been helping out, is being protected, scalable, to ensure that people who should benefit from it are benefiting from it?
All right. Thank you very much, distinguished ladies and gentlemen. Very interesting. And also for me to say welcome to all of you, Dr. Thank you so much. All right. From the ambit of government, you know that NOMIS is statutorily reposited with the Federal Ministry of Women Affairs, and it has actually come a long way. Now, the issue of sustainability of NOMIS is very top in the minds of the ministry, and also not only the ministry, but the government of Nigeria. And I'm also glad to say that the government is not running alone with it, and is also doing its best to ensure that this system do not die, and will actually serve the purpose for which it is built. Part of what the ministry has put in place to ensure that the NOMIS works and works well is to begin to engage a broader spectrum of the stakeholders that should be using NOMIS, so that it won't be like, oh, it's just a system built for a segment of service providers, right, particularly the IPs. No, that's why the ministry has gone the extra mile to begin to introduce it to many other organizations, and also to link up with some other MDAs. The NOMIS has been discussed extensively with NACA. NACA is fully aware and knows the functionality of NOMIS and be part of the process. Ministry of Education has also been part of the operation of NOMIS. And again, to tell you the mindset of the ministry in functionality and sustainability of the NOMIS, to ensure that it won't be tomorrow people begin to picket and find fault with NOMIS. It was worked through with the NIDA, National Technology Development Agency of the government, to ensure that every nitty-gritty that needs to be done in terms of data security, legibility of it, are all covered before we roll it out. And these steps were actually done. Now, the states is also fully carried along in this. That's why sometimes, of course, you know that OVC program is run at community level, which is also under the states and the LGS. So they are part of these systems put together. And we have ensured that data being reported passes through those lines, and they are fully aware. So much so that the beautiful thing about NOM is that it created roles for each of these levels. At the LGA level, you can see the data coming in from the role you play. At the state level, you can also see the flow of your data from your state level. Then at national level, all these things take good care of how the data comes up and who sees the data and who can also utilize information from the data. Of course, the CSOs that are the primary data generating source have also been very, very skilled in terms of usability of NOMIS. And of course, we continue to build the process, continue to train enough manpower, continue to also make NOMIS popular across our sector so that everybody can key into it and use it. It's not going to die. That's what the ministry
I think we are glad to hear that, because for things like this, we would expect that they last for as long as they can. And again, some of the data science activities are made possible through funding from USAID. So I'm coming to you, Dr. Benga.
Absolutely.
So again, thinking sustainability, thinking scalability, what has USAID put in place to ensure that this system lives as long as it should?
Yeah, thank you so much. I know we are having a very serious discussion here. Let me first apologize for not complying with the dress code of the panelists. All right. So, talking sustainability and scalability. So, the question is actually two-sided. We are talking about sustainability, then we are talking about scalability. So, I feel that we are on the right track. I've known Mr. John for a very long time. So, and it's very rare in the public sector where we have an officer sticking to a project or an initiative for that long time. So I'm not surprised that NOMIS is still where it is, and it's even better than it used to be. Those days, it used to be domiciled with just one individual, but now we have an organization that is supporting the government to manage this robust system. So another thing I know about NOMIS is that it's running an open source. Open source is always free, so you don't need to pay monthly subscriptions. We are all aware that like hard package, like Python, is becoming more efficient and even gaining more visibility more than the starter and expert that we used to know. It's because it's free and open source. So another advantage of what we've done with NOMIS, because I know NOMIS runs on Java and Postgres, which is open source, so they're able to interact with other softwares, like you mentioned. So now NOMIS can relate with Lamis Plus. NOMIS can relate with, by the time we optimize it, probably can relate with DHS. If it's not doing that already, DSIM, maybe it's also able to relate with NDR. So because it's low cost, that is actually factoring the fact that it's going to be sustainable. Then number two, I feel that having a community of practice around a thing, where we have a lot of people that are not from one particular organization, can actually help to improve the sustainability. Because staff can go, staff can come. But because we have a system that source software actually embraces collaborative partnership, where maybe organizations that are working and using it can decide to pick a module and actually do something amazing with the module without crashing the entire system. So for example, an organization can decide to enhance the custom reporting module, whereas it's to still be a part of the entire whole. I think it's something we should look at as we continue to strengthen the community of practice. I have a recommendation. I don't know if we are going to be able to get there, but one of the recommendations that I think we should be thinking about is to, I know we organize a lot of webinars, learning series, but they have. So even people that are planning to come into the OVC space can watch those videos and get acquainted with what is happening in the space, the YouTube channel, so that people can, so we can have a lot of people that have knowledge of the use of NOMIS, and who says NOMIS cannot go beyond even Nigeria. It's national, it's not Nigeria OVC management system. So it can go beyond Nigeria, other countries can adapt it. So I think that's my submission. Thank you.
Yeah, that's lovely. That's lovely, and we appreciate those comments. I know, like they always say, for everything that's good, it has a bad side. For every advantage, there may be a disadvantage. Yeah. And so while you're planning to optimize the system, you must ensure that you're covering the base for possible challenges and ensure that it's watertight against anything that could attack that system. So there will definitely be challenges, I believe. And Shea, I'll come to you now. Looking at challenges, what challenges do you see with operationalizing of a system like NOMIS? And what is your suggestion for backup plans to ensure when those challenges come up, we are able to tackle them real time and ensure that the system thrives despite those challenges?
All right, thank you, Dr. Abba. I think most of my panelists have said quite a lot, but so far so good from my experience with the development and the deployment of the application. On the field, we actually experienced and saw some challenges that, if we're able to address on time, would help still allow the people to be able to efficiently use the system. So one of the challenges around connection issue, right? Connectivity. We are quite familiar with, at Arena environment that most of the time we have problems with internet connectivity. So take for instance, DoD explodes a very unique area, right? Where across their entire states where they have their service implementation located, every one of them connect remotely to the central server they have in Abuja, such that when they enter data in all of those places, it comes down here. And that's because many of these facilities DoD has is situated within the military barracks, where you have, at least to a significant extent, strong internet connectivity. So it's quite easier. But for some others, where some other organizations, implementation partners, who provide grassroots intervention support within the community level, in the villages, in these rural areas, you get to understand that there's that problem of internet connectivity. And so one of the things that we've been able to factor in to address those challenges is to see how NOMIs can also run locally on their local device, such that with or without internet, they are still able to use NOMIs. And one of the very powerful things we've been able to do around that, it's the mobile application. So with the mobile application, they are able to, pull in their data from their offices there, take that information to the field, enter the data without internet, and once they're able to access an internet connectivity area, they are able to connect back and then push the information, and it syncs directly to the web. These are some of the things around internet issues that's a challenge, and possibly ways that those issues have been able to, we've been able to put in ideas to address them. Another thing I think we also saw was the concern around knowledge gap. So because we know that to an extent, you cannot stop staff attrition sometimes. There are individuals that you have built their capacity to a certain level, and then after a while, they get probably a better opportunity or something else, either due to migration and every other factor, they leave that position, they move out of that position, right? And so a new set of individuals comes in who do not have full knowledge of the use of this application. Now, that leads me to the suggestion Dr. Gbenga had actually proposed, which is just beyond the webinar setup we're doing to address some of those knowledge gaps, is also to leverage on that ability to have a dedicated YouTube channel for the NOMIS application, whereby as new individuals comes into the system, comes into the organization, they are able to, go there, learn about this application, and are able to use this application to a large extent. Another thing I see as a challenge is the fact that a lot of persons are concerned, knowing fully well that, okay, NOMIS is targeted at client level base. It means that it's not aggregate like we are used to. At this stage now, you are talking about individuals at client level. You're trying to get the information of individuals, their demographic information, their status of vulnerability and all. And so people are concerned about the level of data privacy around the application. And so it kind of gives them some kind of, to be able to address that, one of the key things that the Federal Ministry of Human Affairs, alongside with DataFi, was able to do was to ensure that all compliance with respect to data security, data privacy was followed through with a guideline from NITDA themselves. So NITDA had mandated certain requirements that needs to be enforced before you can be able to roll out such an application. And so all those requirements, with the support from the ministry, we ensure that those requirements were put in place, those processes were implemented into the application, and so that strong assurance was then communicated to everyone, of course through the ministry, that, oh, your data are well secured and protected. Of course, we've talked about the data encryption at rest and in transit. We've talked about the ability for you to have a time log off within a second if you don't use the application. So quite a number of things has been done to address some of these challenges. Thank you.
Yeah, thank you so much, Jay. And it's interesting to hear DataFi's perspective as regards the challenges. But again, we have implementing partners on this panel. So Innocent, I'll come to you. From your own perspective, what's your contribution to this topic in terms of the challenges you see, and what are the possible solutions to mitigate the impact of those challenges on the system?
Yeah, thank you so much. Most of the challenges that we encounter actually is mostly, a kind of a knowledge gap, stuff. We discover most of the times you have to train and retrain and, conduct, refresher training, for the end users actually. And again, staff turnover at, the CBO level usually is an issue too. You train somebody today, tomorrow he's not there, he has gotten a better offer and he has left. So the incoming person you have to train and, conduct another training. So mostly is, most of the challenges is just, around, a knowledge gap stuff. With just few, issues around, the functionality of the app, which is, a daily thing that you can easily resolve through, DEX, just a call and they will resolve it. So mostly just these challenges.
Okay, thank you. So Silas, I would also come to you as regards this. So from your own area of implementation now, DoD, what challenges have you seen with the system and what are the possible solutions to mitigate the impact of those challenges?
So far, we have had a lot of challenges, but over time, we study them and then try to go around them. One of the challenges we had was ability to distribute systems across the whole of the facility, meaning that you have to buy a computer for the case manager, you probably have to get for the AP3 case manager. There are a lot of them working at the facility level. So we have to sit on a table. The professionals have to assess the system and also what it contains. So we currently deployed a Chromebook to our site, not even a computer anymore. It is quite cost effective and easy to manage just on the web. As we deploy them on web, we're able to host it on just on the web there and then use the Chromebook instead of going for an intensive capital computer that we need to use at the site. So that's one of the challenges we encountered and we're able to resolve it over time. And then secondly, issues of attritions are things that we cannot hold. People need to move to another level. But as you said earlier, ability to have a confirmed system on ground where people can visit earlier in time, and if there is a quick attrition at the site, you should be able to quickly also replace the person based on a run-up system, not waiting for a robust training before you take over. So we also have to discuss at the technical working level to see how that will be fixed also. Thank you.
Thank you so much. The good thing about NOMIS is that what has been achieved so far has come because of the coordination from the government and the investment from the government as regards the system. As we go across the states, there are different funding agencies. Everybody has their own reporting requirements. Yeah. And so centralizing the system becomes a little difficult. So, Mr. John, I'll come to you now. With plans to centralize the NOMIS, how are we incorporating the reporting requirements of all the funding agencies and all the stakeholders to ensure that when that system goes central, everybody is satisfied with the system?
All right. Thank you very much. Very, very important and nice question too. And of course, that is the crux of the matter for government too, because we are looking at a system that will be a platform everybody should be using, not just meant for a particular segment, no. And based on that, the government has been engaging with all the necessary implementing partners in the country and be talking to them. And that's what led to the idea of each time we are meeting on NOMIS, we will make it mandatory that it cut across every other implementing partner that is in that state working. And to a very large extent, they've been participating. I'm sure you just finished this presentation where, of course, you heard that CDC has also started the process of deploying the NOMIS in their own states. And I also want to tell you that even some private funders in this country have also seen the NOMIS and appreciated the beauty of NOMIS and are engaging with the government to discuss how can they also be part of that process. This is what the government wants to see happen. And by the time they begin to come in one by one, initially there were these, are they going to take my data? Are they going to dominate me if I begin to use that? But without assurance, without government leadership and commitment to how NOMIS will operate, they begin to see that it's actually meant good to help have information on vulnerable children and their household for the country, not necessarily to pick this person's data and give another person credit. No. So they're coming up, though the process has been slow, and of course you need to understand when people approach you with fear. So you need to remove that doubt so that they can actually come in full scale. So that's the way it is, and they're coming and they're making progress. But another area I would like to point out is the fact that it's also not easy to convince everybody, especially those who are not the original developers of this. So sometimes I'm not at the beginning of this stage, so how do you just want me to come now at this stage to take up? So that's where governments begin to put diplomacy, words of assurance, and be open to it. And of course, when they find out that, yes, this is a purposeful discussion, this is a very useful tool that will address the issue of paucity of data and reporting and orphans and vulnerable children program in this country, you have no option than to join that. And that's why we also tell our line MDAs, please encourage the organizations working with you that NOMIS is born, and NOMIS is for the purpose of all this. And organizations like NACA can discuss extensively NOMIS with you. That's because of the way government has carried them along. In fact, we had planned to discuss with NASCAP, NACA, and Ministry of Health, or NOMIS, so that they see that the interoperability of NOMIS is real, and they see it work. So that meeting is still being discussed with them, and it's going to happen, so that they see that, yes, everybody should use NOMIS, and it's for everybody to use.
Thank you so much, Mr. John. I think it's very impressive to see how the government is really involved and driving the process of the NOMIS in the system. And I think the conversation will not be complete if we don't engage with the audience. So at this point, we'll turn over to the audience to get questions from them so that this lovely panelists here can do well to answer those questions.
All right. Thank you very much. Actually, I'm not going to be asking any question, but I'll just lend my voice because we use NOMIS at the grassroots level. My name is Marcus Williams, the National Coordinator for the Association for Orphans and Vulnerable Children, otherwise known as AON, the civil society network that coordinates VC programming in collaboration with the Federal Ministry of Women Affairs. I will start by saying that the advent of NOMIS under DataFi brought a whole different outlook to the engagement of civil society at community level in terms of providing services to vulnerable children programming. Again, I want to raise a core point, which I think we must mention. In the communities, when you provide service, back then, it's always very difficult to document and then get an accuracy at the other level of documentation before you upload and it goes and all of that. But with this advent, with the NOMIS mobile, as we chose to call it from our end, it is very easy to impute information into NOMIS mobile. And then when you have data, you sync, and it goes straight to the database of whichever agency is responsible for that data collection. If we will tell the truth about ourselves, at the PEPFAR review meeting, I stood up very strongly to mention to PEPFAR that if they don't want to support VC programming again in Nigeria, they should remove NOMIS from their funding. But if they want to continue to support VC programming in Nigeria, NOMIS is a basic thing they must continue to support because its use, its dependency, is localized. We can own it. We can use it. It is something we readily will play with at our level. The only thing we are begging for as civil society is just for DataFi to lift us on board and show us this technicality around what makes it work from the back end so that we can know it after the federal government has given them that opportunity to do that. And once we know it, whether DataFi stops funding NOMIS or not, in country, our support for NOMIS will continue. We are using it, we'll continue to use it. Kudos to DataFi, kudos to USAID, our donor. However, I cannot but say, Sheyi, thank you. Thank you very much.
Thank you very much, the panelists. I'm Sheung. It's for CCCRN. Okay, so my concern is, I've actually been privileged to interface with normies last year. So my concern is, for OVC program, it's basically community focused. Like you go to the trenches, and our case managers are folks that are from those communities. So we actually have communities that are not even that accessible, except you pick somebody within the community, and which might not necessarily be so schooled. So I'm thinking, since we are trying to make normies more user-friendly, can we look at possibility, because our country, Nigeria, we have of different languages. So can we look at a possibility of having like Hausa language, especially in the mobile app, that it makes it easier for the users at the community level to send in information. Then another thing is, still at the user level, I observe we have so many forms, because based on the OVC program is very broad. We have like about 4 domains we are looking at. So we have so many forms that need to be filled into the normies. That's the paper, so many papers filled into normies. But I'm thinking, because on that normies we have, when these services are filled already, like nutrition and you still have service form again, different from the forms that have been filled. And at the end of the day, you still have to come back to the service form and start ticking the services are filled already. So I'm thinking, can we, while we are trying to work on it and do some updates, can we actually make this service form easy in the sense that once I open the service form, I put the date. It just automatically updates all the other services that have been filled into the normies. Then I can go ahead and tick the other ones that does not have a form already filled. Thank you.
Okay, thank you so much for those lovely questions. So Sheyi, I think you would want to take a first stab at the first question. Then maybe Victor, you can respond to the second. So John, I don't know if at any point you would want to respond also. Yeah. So please feel free. So Sheyi.
All right. I think to respond to the first one, like we said, normies is an ongoing thing. The development is an ongoing process. You will all agree with me that compared to when you used to know normies, there's been a lot of advancement and enhancements. And so language implementation, it's something that's quite very unique, and I completely agree with you that it's going to further help even the use of the system across some localized areas. And so be rest assured that, I mean, to a large extent, in the course of this implementation and ongoing development, it's an aspect that will also eventually be factored into the application itself.
Yeah,
Thank you.
Okay, voice, yeah. So to also let the voice to that. Thank you. You spoke like a real programmer and service delivery point, and thank you so much. We like these feedbacks coming from you. And again, the National Technical Working Group on Orphans and Vulnerable Children also do look at some of these concerns you have raised, because when they get feedback from the service delivery point, they translate, I mean, they bring those messages up. But again, to say that normies continue to take ideas from all the stakeholders. By the time we look at this and find out that it's something that will help to enrich the system, why not? It could be done. But I will also not miss word in saying that it's not something we should do today and tomorrow. Because the reason being the fact that Nigeria is a very unique country. There's a way you could start up with that now. Instead of it being an enhancer, it becomes controversial. It becomes something every language would like to be put into it. Before you know it, you run down the system. But we're going to consider this to look at what works and what will give us the best of results, and we'll take it up. Thank you.
On the issue of the forms, the date, that you asked if you can fill the date on the survey form and then it runs across. So one thing I want to highlight is the fact that, yes, we all know that there are quite a number of forms that we use for OVC program. We have had that concern over and over and try to also see how we can minimize that. But for some of those forms are not, none of those forms are, some of the forms are not filled monthly as It's where some of them are one-off forms. You just fill them once throughout the program. You don't need to visit them again. Some are filled quarterly. Some are biannual. So in most cases, you might have one or two that you have to fill every month, basically the service form. So now, if you want to tie the same date across, that might be an issue when it comes to analysis and synchronizing the whole services. Secondly, the date of service delivery might not be the same across the forms that you are looking at. So if you want to use the nutrition assessment, for instance, and service delivery for nutrition, the day you did assessment for nutrition assessment might not be the day you provide young infant services, feeding support. So these kind of things might really, the things we need to consider if we're looking at that recommendation. But just to let you know that using it as a denominator across the forms might pose another challenge that we need to look into critically. But just like Mr. John mentioned, at the level of TWG, these are things we'll consider to see how they play out. If we consider them things that will really enhance the usability of the normies, obviously there are things that will take further. But beyond that, we need to be careful not to make it more complex than it's already. Thank you.
Yeah, so let me a little bit lend my voice to this discussion, most especially around the translation of, the two. I think I also support that. During the COVID-19 lockdown, I think that helped us seriously around, our implementation in Kano, where we have to just improvise, translate some of these service forms to be virtually, administer the services at household level virtually. So it really helps us. It gives us a very good outcome, based on the availability of, the workforce we had then. So we never had any option than to translate some of these tools into the local language, the Hausa, that time. And we had a better outcome. So I seriously support that motion. Maybe we'll look around it. Maybe DataFi will look around it and see where we have, so to really help us in our implementation. Thank you so much.
Okay, thank you for the responses. Do we have any other questions?
No, I don't think so. You can go on.
Okay, so I have one question here that was sent online, so I'll just read it out for us to respond to. So this person says, rather than go to organizations like NIH for data for research in Africa, is this data collected available for further research by universities and research organizations?
Ministry.
Okay, Mr. John?
Okay, of course the data is going to be government-owned data, so it's going to definitely be out in the public domain, so that anybody can access it. If you whatever you want to use it to do, you'll be at liberty to do that. And that's also part of the reason why the government, particularly the ministry, is striving to ensure that the quality of data that we generate is faultless, so that whoever is going to use it, you beat your chest and say, yes, take it to the bank. So these are some of the things the ministry is looking forward to do with DataFi and the rest of the teams that are working that. So long as your data is meet all the requirements of data quality, why not? Anybody can make use of it and be rest assured give you results you want to get. Yeah, thank you.
Okay, please go ahead, Dr. Benga.
Yeah, thank you so much, Mr. John. And I think that's actually the beauty of the leadership and the coordination that the government gives to the implementation of this. So just like you said, I think it's just submitting your concept for approval by the government. And once you have your concept and it's approved by the government, the release, I think, will happen.
Yeah, and just to add, right, so what Director John said is just the way it is. The application, the data is being managed and hosted and controlled by the Federal Ministry of Women Affairs. If you even want to deploy NOMITs across organization now, you communicate DataFi. DataFi will not go ahead to do that. They will ask the permission from the Federal Ministry of Women Affairs, who would give the go-ahead to say, go and do it. So the same way, you want the data, just like Dr. Benga had said. If you write to the Ministry of Women Affairs and they review whatever your things that you have submitted to them, I'm quite certain that they will be willing to release those information for you to carry out your further research or your analysis around whatever it is you are trying to get. Thank you.
Thank you so much, Shay. So it's been a very engaging conversation, and it doesn't end here. We can see these persons and we can always reach out to these persons. So if you still have questions or you need clarifications, please feel free to approach anybody on the panel when you see them outside. So it's been a lovely conversation, even though it was NOMIS focused, but some of the lessons learned can easily be contextualized to other program areas and also help when you're hoping to install or use digital solutions for your implementation. My dear panelists, it's been a pleasure.
Thank you.
Our dear audience, we appreciate you for listening to us. Thank you and goodbye.
Thank you, Dr. Harbour.
Please, another warm round of applause for the panel and the panelists. The moderator and the panelists that just left the stage. This is just a warm reminder that we have the pictures from yesterday ready, and the barcode will be projected on the screen. So feel free to scan it to see your beautiful pictures. Feel free to post it on social media and tag DataFi Project at DataFi Project. You'll find us on LinkedIn and Twitter. Remember, the hashtag is DUF 2024. DUF is DUF 2024. Okay, they are up on the screen. You can find us on X and you can find us on LinkedIn. DataFi Projects, that's the handle. The hashtag is DUF 2024. And that's the code for the pictures. Thank you so much for your patience being with us since morning up until this minute. We know that some of us, we are all famished, so lunch is served. We'll be back here in the next 40 minutes to have the last session for the day, and then we would call this a wrap-up. Thank you and enjoy your lunch.
right, Pamela. Can you hear us?
Yes, I can.
Hey.
But I can hear feedbacks.
Good afternoon, everyone. Good afternoon, everybody. Are we too full to respond? Welcome back from lunch. So we have one more session before we call it a day. So I'll just be quickly introducing the next person who will be coming on to give us the youth perspective on digital health for improving community health outcomes. And we have somebody who is a health activist and social development leader who is passionate about providing equitable and sustainable access to healthcare for people in rural and underserved communities in our country, which is Nigeria. She's very passionate, and we have no doubt in our mind that she'll do the best with this topic. So she'll join us virtually, so I'll call on Pomile Ogunjemite to give us her presentation on this. Please, with a round of applause, let's welcome Pomile to give our presentation. Pomile, can you confirm you can hear us?
Yes, I can hear you. Good afternoon.
Okay, please, take us away.
All right, thank you so much, everyone, for the opportunity to be here. I'm particularly grateful to Data IFI and all the sponsors of this event for the opportunity to showcase how we as Pioneer Medical Initiative are using to improve healthcare outcomes in rural and underserved communities in Nigeria. A little bit about myself. My name is Pomile Ogunjemite, and I grew up in a low to middle income community in Nigeria. And by that means I hardly had access to primary healthcare services while growing up. It was very much a luxury for my siblings and I, and not just my siblings and I, but also for a number of people around us to go to healthcare services or go to any form of hospital to access care. We often relied on alternative methods and always thanking God that we didn't end up in the hospital. And this was not just the case for myself, who grew up in a community that is several steps ahead of rural communities in Nigeria, but it also reflects about 40% of Nigerians living in rural communities, and also importantly, with many of them living in extreme poverty. This describes how they interact with healthcare, always looking forward to opportunities or praying to God for opportunities not to be users of primary healthcare services, especially those that require inpatient care. So this led me down the path of advocacy and activism when I founded Pioneer Medical Initiative in 2018. And since then, Pioneer Medical Initiative has engaged in different forms of primary healthcare services delivery. We're particularly focusing on 3 areas of primary healthcare delivery, and one is the one-stop shop for health, which is the highlights of our Health for Rural program. Secondly, we are strengthening rural and local healthcare facilities in order to enable them to deliver care more efficiently and effectively. And also, we are engaging with rural dwellers to understand their problems, their insights, and using healthcare as a tool for holistic healthcare, holistic rural development. Today, I'm going to be focusing on two of those ways where we have used digital technologies to provide care in rural communities. And the first of all is telemedicine, the second being MedIQ. So after deploying our one-stop shop for health solution under the Health for Rural program in partnership with our hospital partners, we realized that we needed to have efficient doctor oversight in order to complete the service chain. So this needed us to set up telemedicine services, as many doctors or most of our doctors were not available to serve in rural communities, even for short periods of time. So this needed us to think outside the box, and that's also because of the challenges typical of rural communities. For example, internet access is usually very poor. Also, smart devices are not very popular. So we had to technically delete that box and think of how we can still bring telemedicine, especially virtual consultations, down to rural communities. The first thing we did was to identify the areas with internet access around the communities. And for some communities, especially for Aukajola, which is our first community, we are able to identify some which were some kilometers away from the center of the village. The next thing we did was to liaise with the community members to set up logistic plans. And in cases where our community health extension workers could not properly care or require doctor oversight, and where the patient is unable to afford the cost of going to a public facility or a private facility at the nearest center, we used telemedicine to bring them to the doctor. Also, we've been able to fund these services and ensure that the cost is not so high on the villagers through partnership with private organizations such as Fembo Group that have funded the one-stop shop for health and telemedicine services in these communities. Secondly, the second way we are using technology is MedIQ, which is an electronic public health record manager developed by my team. As we grew and continued in our services as healthcare providers in rural communities cutting across states, data management became a key problem for my team and I. Usually, when we started, we're not so concerned about data. We were basically using self-test kits to test the rural communities and to deliver care. So it did feel like a lot of work, a lot of hassle to keep using paper-based methods. However, by the time we trained a number of activists, youth activists, which is now numbering over 500, realized that each of the outreaches they are doing in their communities needs to be better integrated and documented. And this was what brought about MedIQ. Also, we realized that this problem is not just a problem for Pioneer Medical Initiative. Importantly, a lot of out-of-hospital records are roaming everywhere. For example, a lot of youth-led initiatives working towards Sustainable Development Goal 3 and the Universal Healthcare Coverage Agenda oftentimes do not have appropriate softwares or tools to manage data. Also, a lot of religious organizations are constantly conducting outreaches, and the fact is many of these outreaches are really reaching neglected communities and can provide a lot of significant insights. So we thought about why not just solve ourselves first and then think about how this software can also help other people to problems. This was how what led us to developing our minimum viable product, which was a low-code solution for the in-house management of project data in our Kajola community and all of our other outreach communities. This software is optimized for offline functions. It also offers valuable insights to telling holistic stories. So at this point where we started using this software, we started thinking more about beyond the immediate healthcare data that are collected in the communities to how we can also understand the social determinants of health in these communities and tell stories that can include and invite other partners into assisting them. So literally us using healthcare as the wheel for steering all around growth and development in these communities. So our MVP, like I mentioned, was made of low-code solution and it's still currently being used by the team. Please, if you don't mind, I would like to confirm that we can still clearly hear me.
Yes, we can hear you.
Can we hear me, please?
We can hear you. We can hear you. Please go.
All right. Thanks. Yeah. So, talking about we were able to categorize the modules of the software into three categories. First of all is the communities and the peoples, with non-profit organizations like ourselves that, and also other small organizations, especially small-scale organizations and social groups that are delivering healthcare services, especially in forms of outreaches. We realized that we need a more dedicated system that can cater to the type of data we are collecting, the scale of data we are collecting, and also the peculiarities of the communities we are working in. So our data was, the first module is the community/people. And this data of medical data collected during the outreaches are organized by communities, such that if we want to look for the data on a particular community, first of all, we need to look at the community name, and we break it down into the people that we understand, okay, the last time we were here, what happened, what was the reading, the next time we are here, what were the reading. Now we're able to make and draw a lot of conclusions. It's also aided our telemedicine services, especially for doctors that were not on site. The second is the survey, which is also the part that we use for community healthcare assessment. We started becoming more intentional about documenting things like environmental factors impacting their health. Was waste? How are they managing their waste? What about the water sources and all those other things? The third one is the inventory. So currently, how we're using the inventory is in the one-stop shop for health, which we deployed with our hospital partners. But this inventory section is also able to document interventions such as distribution of mosquito nets, for example. It's able to help to identify who exactly received this intervention, and if follow-up is needed, you know exactly who took the intervention, are they still using it, and how has it impacted, for example, the children in those households from having malaria regularly. So the inventory can be modified. But the interesting thing about the software is that we've also been able to adapt it to various forms. For example, working on Project Help, which is focused on strengthening local facilities with medical oxygen, we're able to adapt it for our questionnaires and all. Also working on Health for Rural, we're able to adapt it, document the undocumented, and various other projects. This is just to highlight that it is able to, it can be adapted for different organizations once the use case is determined. So our aim primarily with MedIQ stops being just documenting our own data internally to bring in visibility to the healthcare needs of underserved communities. So many neglected and very interior rural communities need their stories to be told. For example, I remember as a student taking action, many times I particularly went to Federal University of Technology, Akure, and for every opportunity, students' communities had to do outreach. We wanted to go to Ibuleshoro, not because Ibuleshoro was the only community, but that was the community we knew, and that was the community close by. However, because I interacted more with that community, I realized that there were a lot of rural communities around that area that could actually also benefit from many of these programs that students, innovators were deploying. But because of lack of knowledge of these communities, these social interventions do not reach them. So it became important for us to not just go on one-time outreaches, but also to document the needs and let other social innovators, especially in the social sector, to be able to know communities, find communities, and deploy the interventions they want to give to them equitably across groups. So the MedIQ was able to successfully replace this database, although we still have issues with ensuring that it can capture every single thing we are doing, and still sometimes because of so we don't lose data, we still back it up with paper. But essentially, we've been able to switch from fully relying on paper-based solutions for our data management to using MedIQ to digitalize the process. I already explained some of the communities that we are targeting. They are rural and underserved rural communities, populations of at least 250 people, communities that are economically active with potential for economic growth, and usually they have either no healthcare facility or dilapidated healthcare facility. Our first attempt to tell the story of our communities was talking about Awokajola, where we spoke about the social factors, the cultural, the demographic, the infrastructural status quo of that particular community. More and more with insights from data, we hope to be able to back them up with data and recommend interventions that social innovators should pick on, and also be able to consult them on how they can successfully implement those solutions in rural communities. So what next for us? What next for MedIQ? Having used low-code solutions, we are working on developing code-based application, especially the mobile application that's also able to work offline. We're also looking to expand beyond PMI. Currently, this software is primarily used by our organization to manage our own data across states, but we're looking at also extending it to other non-governmental organizations, small-scale non-governmental organizations, and also to other social actors or well-meaning individuals that are looking for suitable means of managing their outreach data. Also, we are looking to tell and create more effective ways of telling stories for rural development, using the data, the insights, understanding of social determinants of health to tell compelling individual and community-based stories without necessarily revealing important personal data that must be protected. So here's my team. Currently, we have been able to deploy this solution across all the states in Southwest, and we are looking to expand beyond Southwest in the latter part of this year. We have been able to train over 500 youth activists across the 6 states of Southwest, with a number of people now migrating to other parts of the country and taking actions there as well. Also, we've since the beginning of Pioneer Medical Initiative, we've been able to reach over 10,000 people in rural communities and through the activities of our young activists. We look forward to a situation where each of those people we've documented and rather the records of those who have been lost in the early stages of Pioneer Medical Initiative would not have to repeat itself, but there is a situation where we are able to use the software to capture the data of everyone we have been able to reach, to also be able to offer this data as meaningful insights and to help every other meaning individuals and social organizations to do the same with the data they are capturing through their social actions. So talking about the youth perspective, what are some of the concerns that I think myself and other youth innovators are having when it comes to data management and all? So first of all is I was able to join the session just some parts of the sessions today, and a lot of these concerns have been spoken about. One is there's still a lot of fragmentation happening. Also, we need to standardize the data because of the scale in which these outreaches, these programs are happening, but the ability to also provide meaningful insights and track intervention across the country. Okay, I don't know if you can hear me, but I think you can. But because of also the ability, we think there's a need to also bring standardization to the process. If also, another concern is if solutions like ours and other youth innovators choose to integrate with existing national systems, who is going to own the data? I think data ownership is a thing, and we really want to know how data ownership is going to be addressed, also how it's going to be integrated. I would want to know what regulatory efforts are going to be put in place to make this kind of innovations more youth-friendly and encourage people to think beyond beyond the risks that we have associated with data management that is putting a lot of people off, especially data security, to embracing more data-friendly systems in distributing or implementing their social innovations. Finally, in conclusion, I believe that the future of healthcare is digital and it has to be equitable. We need to also include diversity in two forms. Diversity in terms of the communities that are reached, hard-to-reach populations must be included, and also small and medium-scale organizations that are not able to afford the current cost of data management systems. We need to create solutions that are more inclusive of this population. So we need diversity in data management space. We need the inclusion of all organizations and communities. And I think it needs to be equitable and no one must be left behind. Thank you so much for listening to me. I am Pamile Ogunjenite. Yeah.
Please, we can do better than that for that presentation. It was a very energetic and informative session. Thank you so much, Pamile, for that presentation. So I don't know if we have any questions for Pamile. So we could ask before we tell her to come down the stage. Do we have any questions from anybody in the house? Okay. So Pamile, please still hang on. We have some questions here from the room.
Yeah, good afternoon. My name is Elijah from AF. So I thank you very much for the presentation. Very energetic, very enthusiastic. Thank you for the great work you're doing. So I want to know the what are the type of medical services that you provide within the communities, and what population are your services focused on? Thank you.
Pamela, if you can hear me, we can't hear you.
Oh. Can you hear me now?
Yes, we can. Go ahead, please.
Okay, all right. So the services we currently offer within the communities are those that are using self-test kits, and that's because for most cases, our solutions are mobile. For example, testing for blood glucose, testing for blood glucose, their body mass index. In some cases, we include hepatitis solutions, and if the doctor recommends, we also conduct HIV tests for patients that I suspect are having those conditions. But primarily, the tests that we currently do are those that are very mobile and that can be done using self-test kits. And our populations, we are focused on primary healthcare services. So our populations are, permit me to stop sharing screen for a moment. So our services are primarily for primary healthcare delivery. Apart from offering outreaches, we have also been able to develop or deploy interventions like AirHelp, which is where we are partnering with other startups, for example, HealthPort, to strengthen local facilities with medical oxygen supply. And in AirHelp, for example, what we're doing is to give them oxygen plants. HealthPort already has these plants. Well, for example, oxygen cubes, and they are seeking out to rural communities and empower them for better primary health care delivery or secondary health care, as their own case may be. So our services are primary focused, either strengthening needs or delivering needs to communities that currently do not have through our hospital partners.
All right. Thank you very much, Pomile. I just want to ask a question. My name is Damola. I just want to ask a question around the telemedicine. Is it that you have an Android app for your telemedicine? Is it a full-blown telemedicine? And one more question, is it incentivized in terms of how do you pay the healthcare workers, or is it on volunteering platform? Thank you.
All right. Thank you for the question. So our telemedicine solution currently is not paid for by the individuals because of the existing network of doctors we have as a non-governmental organization. We are able to connect volunteer doctors to rural communities. This is one thing that helps us to bring down the cost of the telemedicine. However, we've also been able to work with private funders, for example, companies that want to do their corporate social responsibility, to be able to fund other components, other costs that we incur in the process of the care delivery. So our telemedicine services are delivered by volunteer doctors, but other costs components are funded by private partnerships. So you asked if the telemedicine is a full-blown software. No, at the moment, we are not. We use really like tablets to connect using existing platforms like Google Meet and Zoom. By the time we develop our code-based software, the MedIQ, we hope that when we are done with that phase, we start looking at developing and not like a software that will be dedicated to telemedicine. But because we need to optimize our resources at the moment, we are not developing a telemedicine software. We are focused on developing the public health record manager that we're currently working with, and later the telemedicine software.
Any other questions for Pomile? Any questions, any comments? Okay, Abba.
Okay, so I can see one question here online, Pomile. So the question is, have there been any challenges with the rollout of your application? And how have you been able to circumvent those challenges?
Rollout of what?
of the app you spoke to us about, has there been any challenges encountered with the use or the rollout of that particular app here?
Oh, yes, we definitely had a number of challenges. And in the presentation, I mentioned that sometimes we still have to back it up with, at some point, we had to back it up with paper to make sure that we do not have data loss. For example, I remember there was a time we were going to implement it in a new environment. For example, we're used to using it in Ondo State and wanted to go to Ogun State, but realized that after the outreach, most of our data did not synchronize. So we had some of them synchronizing. That's because the app is meant to work offline. But we realized that at that particular point, we had some data loss. However, our technical team have been able to work out why we had that challenge, and some of which were simple things like the device we're using going off even before the data was stored, and a number of other things like that. So we've been able to optimize for some of these challenges we experienced. But in terms of other challenges like being accepted by the rural communities, we've never had situations where our villagers were a bit withdrawn from using either the telemedicine solution or having us attend to them with laptops or mobile devices in front of them. They were always very welcoming of those.
Okay, thank you so much, Pamela. It was indeed a very energetic presentation. There are no other questions from the house, but we appreciate you for taking out time to come and talk to us. Thank you so much. A round of applause, please, for Pamela. Okay, so we are gradually winding down to these wonderful 2 days we've had together. But before we eventually call it a day, we would like to just take responses from 2 persons, 2 volunteers. What has your experience been with DDUF? And if you are being asked, how did the program go? How did the forum go? What would be your exact words? 2 keywords alone. We need your feedback. And Damola, I saw your hand up.
Well, 2 words I can say have been very educative and very interesting.
We appreciate you, sir.
For me, let's do this again, please. Thank you.
More than 2 words, but we'll take that. Any other person in the room? What has the experience been?
It's been experience sharing for supporting states.
Experience sharing. Thank you so much, sir. I saw Winifred's hand up.
Yeah, for me, it has been a wonderful experience because get to hear different persons talk about what they are doing, and then the most interesting part for me is the ownership from the state team that are present in this room yesterday and today. So it's shown that there's this thing we're talking about, sustainability is actually doable and achievable. So thank you to Data5 for putting this together.
Sustainability and ownership. Any other person?
Just 2 words, quite challenges, especially from government side to do more in terms of ownership and trying to put more effort for sustainability.
Sustainability. We appreciate you. Any other person?
Thank you. It's been very thought-provoking and insightful. So I got to learn a lot of different perspectives to issues. Collaboration is one key. Like, it's very important to come together to get a solution, because sometimes you're designing a solution from one perspective and the outcome may not just be all-encompassing of the opportunities that lie to achieve. So thank you.
Thank you so much. Thoughts-provoking and insightful. I think that more or less highlights how these 2 days has been. But we have our founder here, and we want to take some last words from USAID before we close. So, Dr. Austin, I don't know if you could do us the honors. Your last words for us.
All right. Standing on existing protocol, I just want to thank everybody that's made time to come for this event. Of course, thanking our other our co-donor agencies, CDC, I saw them here, DOD, as well as I'm not sure if the UN and WHO team were here. Sending a very big thank you to the Palladium DataFi team. They've done a great job, not just with this event, but generally with our implementation on the digital space in Nigeria. And to the state and to the UN team, both federal and states, thank you as well. We are hoping that this can happen a lot more, not just once a year, but as much as we can, for the funding from both USAID and maybe even government and all of that. But just to say, we are really, truly grateful. This event has been quite, for me personally, has been very informative, and I would love to see us do this a lot more this year. Thank you very much.
Thank you so much, Austin. Okay. So, because of time, we will be taking our closing remarks now from no other person but the country director of DataFi. So please, with a round of applause, let's invite him to give us the closing remarks.
Wow. I think it's been a great 2 days. And where do I start? I don't know. But I must start somewhere. We started yesterday with opening remarks and participation from government entities. So I want to start by thanking the government of Nigeria, particularly FMOH, the Department of Public Health, the Department of Health Planning, Research and Statistics, NCDC, they were here represented. They gave a goodwill message yesterday. So I want to say thank you to them. I want to say thank you to the state team. And I'm saying this, the thank you I'm saying here is not in any particular order. But to say thank you to the state team, and I will mention the state team, Akwa Ibom, Dr. Antia, the DPH that led the team. Thank you very much for coming. It's really appreciated. Thank you for the good work you're doing, and the Akwa Ibom team. For Edo State, Dr. Stevenson, thank you for leading the team and for the good work you are doing in Edo State. For Oyo State, Dr. Karim, saw her somewhere. Okay, thank you very much. Thank you for leading the team and coming over for this event. The Digitaka, Dr. Danjuma, thank you very much for leading the team here in Abuja. We hope to have to come back to Taraba to do more work with you. So thank you for the work you do and for leading the team here. For Adamawa, Mr. Titus, I look forward to coming to Adamawa. The promise, I want you to fulfill that promise. So I'm looking forward to it. Thank you for leading the team and thank you for the work that you do. Mr. Awal from Bauchi, the state emit focal person, thank you very much for coming. It's really, we really appreciate your coming and the work that you do. I know there are some of our other states that are not here, Kano, Niger, Cross River, but the state SIs are here, but I want you to convey our thanks to your state leads and thank them for the partnership that we have with them. We had a presentation from World Bank earlier today, just to say thank you to World Bank too for the work that they are doing. We look forward to partner with them more. You know, this event was created for multiple folds, not even one or two folds, is to exchange learnings. That's one. Then to actually put ourselves out there as an organization, to look at what we have done over the past five years, for you to critique and tell us where we are going wrong and what we need to do better. There were a couple of recommendations that came from the panel sessions,
And we've noted those recommendations down, and these are the things that we're going to implement to improve our services going forward. So I want to also say thank you to all the partners that are here, the implementing partners, the USAID funding implementing partners that are here. Thank you very much. To US CDC, DOD, and the PEPFAR office, thank you very much for being part of this. It's really great to have you and to have you support us. Also to say thank you to Africa CDC. They were very much represented and contributed very much to the work that we are doing. Dr. Dauda is no longer here. He had to step out, but to say thank you to him in absentia. All the panelists, so that I will also thank myself because I was also a panelist. So all the panelists, thank you very much for your participation and your the deliberation, your recommendations, and all that. I also want to say thank you to the academia, Bingham University. Thank you very much for coming. We look forward to more collaboration, and we hope that this will lead to more fruitful engagement going further. Thank you to WHO for being here. We appreciate your coming. I don't know if UNAIDS, I know we did an invitation to UNAIDS. Thank you to UNAIDS. Thank you to NACA for being part of this event. Finally, no, before I say finally, who do I thank last? Is it my funder or the DataFi staff? Please help me. My funder, okay. So yeah, my funder has it. So I want to say thank you to the DataFi staff. Please, can we just give them a round of applause? They've done marvelously well. I think it took about 2-3 weeks to put up this event, even though we have been planning. But when the real engagement started, it's about 2 or 3 weeks or so for us to be able to put up this event. I thought I was a gentle. I didn't know I could drive them this hard, but this period I really drove them hard. I was on their case, following up to ensure that everything went right, and I'm really, really excited about what we have today for the last 2 days. Please just give yourself a round of applause. It's a great job. I will not be able to mention everybody, but you all know yourselves that have worked on this, and thank you very much for this that you did. Like they say, reward for good work brings more work, right? So we'll look forward to other events that we'll be hosting in the coming months. Finally, I want to say thank you to USAID. If not for the funding that we have on the COVID grant and also on the HIV grants, we would not have been able to do this. So thank you very much for your funding, for your support. Austin, Bayo, I was with Bayo in Edo when the commissioning happened, and he's still here to support us. So thank you very much for your support. Even though we fight sometimes and we do back and forth sometimes, just to let you know that you are really appreciated. We appreciate your support. We appreciate your guidance. We also appreciate the money. So thank you very much. Finally, to everyone that I have not said thank you to, please accept this as a thank you to you for being part of this event. Thank you very much for all the state SI leads, for the HI team in DataFi, for the DA team, the admin team that work behind the background that we don't usually say thank you to them. Thank you very much. To the COVID team, thank you very much. I'm missing one team. To the research, the research and survey and surveillance team, thank you very much. And we'll look forward to having another of this in the coming months. Thank you and have a good evening. I just forgot someone. Abby, one name, like I call her. Thank you very much, Abby. Abby works on a sister project in Palladium, and she graciously agreed to MC this event for us for the past 2 days. So I just want us to give her a round of applause. Thank you very much, Abby. I didn't know you had these skills, but thank you for being part of DataFi.
Thank you.
Thank you so much, sir, for those closing remarks. Any attempts to add to this will be doing too much, I must assure you. But we appreciate every single one of you because when we started, it was a dream. We ensured we planned very well. But the truth is, despite the planning, if you didn't show up, it would have been in vain. So thank you so much for being part of this. Please, a round of applause to yourselves. It is our hope and wish that this doesn't end here. The conversations continue outside this space. We continue to collaborate, continue to join hands together, and ensure that we fully digitize our systems and we have the best outcomes for our patients across all disease areas. So thank you so much for being part of it. I can assure you that without you, success would have been a mere mirage. We appreciate you. For myself and Nabi, thank you so much and have a wonderful evening.
Thank you so much.